All right. Well, good afternoon, everyone, and welcome to the first ever HealthInno Health ImpACT Virtual Kickoff. I'm Joseph Sapien, Program Director at HealthInno. Today is about bringing national insight and New Mexico priorities into a closer connection so we can move towards real deployment and partnership. A few housekeeping instructions before we launch. We welcome you to keep your camera on throughout the event. Please use the chat for questions and open dialogue. Our team will monitor the chat and surface questions to speakers, time permitting. All attendees will remain muted during the program. This event is being recorded and will be made available publicly in the near future. Closed captioning is also enabled if needed. To open the program, I'm pleased to introduce our HealthInno leadership team, Angelica Maestas, founder of HealthInno and Director of Strategic Partnerships at Builders VC, and Stefany Goradia, Executive Director of Innovation at HealthInno and Healthcare Researcher with UNM Center for Health Policy. Welcome.
Thank you, Joseph, and welcome everyone. I'm Angelica Maestas, and I worked across nearly every corner of the healthcare ecosystem, inside payer and provider organizations, as a health tech founder, an investor, and now as an ecosystem builder, which is why I know firsthand that the problem we're solving with Health ImpACT is real. Today is the official kickoff of Health ImpACT, a statewide health innovation initiative led by HealthInno in collaboration with Builders VC, UNM HSC, and funded by the New Mexico Economic Development Department. For those who are new to us, HealthInno is New Mexico's statewide center for health tech innovation. We build the infrastructure, partnerships, and programs needed to advance healthcare innovation across the state. We've convened healthcare and public-private partners statewide through our annual summit and events. We provide education for the next generation of healthcare leaders and clinicians on technology, innovation, and investment. And now we're launching the state's first health innovation pilot and learning network. And that's what we're here to talk about today. Health ImpACT is that network and one of the most significant ways we're putting this work into action. Earlier this year, HealthInno was awarded an $844,000 grant from New Mexico Economic Development Department to build a statewide pilot network, connecting healthcare organizations to vetted health technology companies that are addressing real operational, clinical, and community health priorities. The challenges we're addressing, which you see here on the left, is that healthcare organizations are being asked to solve increasingly complex problems, workforce strain, access gaps, rural care delivery, chronic disease, and the responsible use of emerging technology. At the same time, startups are building promising tools, but often lack a clear path to understand healthcare priorities, workflows, and what it takes to become a credible partner. Health ImpACT is designed to close that gap. In case you're wondering, the ACT in Health ImpACT stands for Advanced Computing Technologies, things like AI, big data, and complex computing. It's a state economic development priority and something that we believe holds a lot of promise in healthcare. We also believe New Mexico is uniquely positioned to lead this work. We have committed healthcare leaders, research and data science expertise at our universities and labs, entrepreneurs building here, state leadership willing to invest, and urgent challenges that demand we think differently. We're not just reacting to innovation happening somewhere else. We can shape what gets tested here, what gets learned here, and what scales from here. But we aren't going it alone. We welcome input and involvement from everyone in this room. We're guided by an advisory council that brings together experts across healthcare delivery, economic development, and investment in New Mexico. They help us make sure what we're building is grounded, rigorous, and aligned with what New Mexico organizations actually need. And I want to take a moment to recognize and thank them. Ryan Cangialosi from UNM Health Sciences Center, Jeff Flores from Mecca Therapies, Dr. Denise Gonzalez from Presbyterian Healthcare Services, Dr. David Wang from Loveless Health System, and Dr. Amit Mehta from Builders BC. We're not building this from scratch. Models like this exist across the country. States and health systems that have built structured pathways for healthcare organizations and innovators to work together, test solutions, and scale what works. Matter in Illinois, Prime Health in Colorado, HTA in Arkansas, and many more. These are all proving the model. New Mexico hasn't had that until now. What we're building with Health ImpACT is informed by what's working nationally and designed specifically for the assets, needs, and communities of our state. In order for this model to succeed, it's going to take the right infrastructure, the right partners, and a clear understanding of how all the pieces fit together. And Stefany is going to take us deeper into exactly that.
Awesome. Thank you so much, Angelica, and welcome everybody. It's so awesome to see such a full house and see some familiar and some new faces. We can't wait to get to know all of you. My name is Stefany Goradia. For those of you who I haven't had the pleasure yet to meet, I have spent the last 15 years embedded inside Medicaid, managed care, health systems, and health data and technology infrastructure. I've also sat on the founder side as an exited entrepreneur, and now today I wear two major hats. One at UNM as a healthcare researcher, policy analyst, and health equity sciences doctoral student, and another hat, of course, helping to build HealthInno New Mexico. And all of this experience comes together for me and is exactly why I know that the gap that we're closing with Health ImpACT is not just theoretical. And today we're here to talk about what it means to move it into actionable practice. So over the past year, we've been strengthening the health tech ecosystem here in New Mexico, including a health executive dinner that we hosted earlier this year. And we've heard a consistent message. Healthcare organizations across New Mexico are interested in innovation, but they don't always have the bandwidth or the time to figure out what's real, what's viable, what's worth piloting, what's even out there. At the same time, we have startups that are building promising tools, cutting edge tools, nimble tools, but they often don't understand exactly what it takes to work inside healthcare, or they don't have the connections or the community to get in front of the right person, and things like that, that all influence uptake and adoption. Health ImpACT is the connective infrastructure that's going to help close that gap and to make innovation more equitable across the state. What that means to us is making innovation accessible to providers and systems of all shapes, sizes, and regions. What Health ImpACT brings is a repeatable process, technical assistance, and of course, data-driven outcomes evaluation for identifying what healthcare needs here in the state, helping to vet solutions that fit here for our communities and with our mission, and supporting pilots, and learning from what works. And as Angelica mentioned, we're building the Health ImpACT Pilot Network in close collaboration with UNM Health Sciences Center and Builders BC. But that said, everyone here today has a seat at that table, which is why we've invited all of you. Because Health ImpACT really is bigger than two-sided matchmaking between healthcare organizations and startups. Certainly that's the nature of the Health ImpACT program. But what we're working on here more broadly is a statewide innovation effort, statewide innovation backbone. We want to align care delivery needs with economic development, public policy, venture and other sorts of investment capital, researchers and labs, workforce development, and community insight. Because when all this comes together into a strong health technology and innovation economy, that brings more modernization options for our health systems and our clinicians, more high-wage jobs for our workforce, especially those in rural areas, more opportunity for entrepreneurs, for mission-aligned clinicians, companies, and builders who want to grow here and are attracted to technology. And most importantly, it builds a stronger healthcare system for all of us. And like strong innovation ecosystems in other regions, as Angelica mentioned, venture and other capital mechanisms are critical to this work because we see them as bringing in more resources and more opportunity for us to make this work happen, as well as bringing in sort of a national lens on what's being built, what's going on elsewhere, and where we can help startups that may typically fall short when they're not implementation ready or workflow aware. But all of this said, the people who are going to make this work real here in the state are not just us, it's you all, the people with local context, you all who are actively delivering care, doing research, shaping policy, all of the people in our state who care about our communities and who are grounded in what our local context means. And that is everyone here in this room today. So this initiative is not just about venture or startups or even HealthInno leading this strategy. It's about giving everyone, especially our healthcare leaders, the platform and the process to shape that. So we don't want to import solutions blindly. We want to build a smarter, more coordinated pathway for innovation that actually fits here in New Mexico, for New Mexico, by New Mexico. And every single one of you have a role in that, as you see here on this slide. So here's how we think about it a little bit more concretely. If you're a healthcare organization, clinician, a healthcare leader, a healthcare administrator, a healthcare champion, you are the starting point. Health ImpACT is built around your priorities. We want to work with you to surface what the real operational and clinical challenges are that you're facing. We want to help identify and help vet solutions that could fit those needs. And we want to support you, we and others, through the entire pilot process from start to finish, from scoping to evaluation. So this opens it up for folks who don't have a dedicated innovation team to participate. That's what we're here to help to provide and what our funding helps to provide. If you're a startup or health technology company, whether you're headquartered here in New Mexico or you're coming in and interested in working and partnering with New Mexico healthcare organizations, we want to know what you're out there building. We want to see how and where it fits into what our unique healthcare needs and challenges are. Our application process is designed to assess maturity, implementation, and alignment with our partners and what they're naming as priorities. If and when there's a fit, we'll help connect folks and connect the right partners and support through the pilot process. So unlike a pitch competition, this is really a pathway or a pipeline to real partnership and ultimately transformation. If you're in academia or research, you're also a critical part of making this work matter beyond any single pilot. We do need and want partners who can help design rigorous evaluation, capture meaningful outcomes, and generate evidence that travels. So whether you're with academic health, practicing clinician, implementation science, working in health equity, whatnot within New Mexico, we will be working closely with our academic institutional partners to create funding and partnership pathways for exactly that. And finally, if you're a all other policymaker, economic development leader, investor, community partner, you belong here too. We do see this as the beginning of a long tail effort, and the work only succeeds and sustains into the future if it reflects the communities that we serve, but most importantly, if we all together create and help to create the conditions for innovation to take root here long term in the state. So as you listen today, I hope that you will keep those questions in mind. Where do you fit? How can you engage? How do you want to engage? And what role can you help play to tangibly help move this work forward? We're interested in hearing from all of you, and there's a place for folks who want to be involved in helping shape this work. That's what we're about today. So today is the beginning of that working network. We're inviting everyone to be a part of it. So with that said, today you will hear from national innovation leaders who we are honored to host and learn from. You will hear from health systems and what kind of innovation models are emerging and evolving and exist out there. You will hear from startups and health technology companies who are working on real healthcare challenges right now. And of course, we'll hear from New Mexico leaders who are shaping a broader healthcare vision across the entire state. Because we want everyone here to understand not only the national momentum, but also how New Mexico can take what's working and leave the rest for something that works for us. And so while not everyone that you'll hear from today is part of Health ImpACT, everyone here is invited to give us context, perspective, and inspiration for what we're building. We hope that many of you will help us shape this in the years to come. All right, with that, we have about 5 minutes for preliminary questions. Does anyone have what questions you have from us based on that? Great question, Dr. Epstein. We have close collaboration with all of those folks. In fact, we partnered most recently with CNM Ingenuity on our workforce development bootcamp, where we graduated our health tech 9 or 10, was it, health tech innovators. Certainly through our partnership with UNMHSC, that opens up the doors to Rainforest and others. And we invite others, especially angels, ventures, other funders into the ecosystem. While UNMHSC and Builders VC are our initial collaborators, this is an open community and an open ecosystem with lots of ways for folks to plug in. We, of course, as you know, hate to duplicate anything. We don't want to replicate anything. We don't want to recreate any wheels. And so we look forward to collaborating with others who have strengths, relative strengths, and extensions of things that we do not.
And I think we're at 120, Stefany.
Oh, my timer's off. Okay, awesome. All right. Well, with that, I am honored to introduce our keynote speaker for the day. To help ground the national landscape, we're honored to welcome Stefan Konya, Chief of Innovation and Strategic Partners at the U.S. Department of Health and Human Services, Office of the National Coordinator for Health Information Technology. Stefan will bring his national perspective on health IT strategy, public-private collaboration, and what it takes to move from fragmented innovation efforts to models that work across systems. So, Stefan, thank you for joining us. I will turn it over to you to share.
Great. Thank you so much, Stefany. And thank you, Angelica. Quick sound check. Can you hear me okay?
Sound great.
Perfect. All right, let me go ahead and get my slides working here, just to make sure we're good to go with that. All right, do we have a good clear shot of the slides? Perfect. Well, again, thank you to the two of you for inviting me to be part of this momentous event and occasion in growing the New Mexico innovation ecosystem around healthcare and life sciences. It was great to meet the two of you over the past few years and share your story about what you're trying to build there in the New Mexico region. And, having spent the past 20 years nationally working on innovation ecosystem building, with an early part of my career being more focused on it from the economic development lens, hopefully I'll be able to share some of my insights, best practices, lessons learned over the course of this presentation. And then also tie it back to how it can support advancing, healthcare innovation and specifically, and how it can improve outcomes, quality care, all of that, and how it ties in with a broader national agenda that we have around adopting digital tools in the field of healthcare and so on. So again, Stefan Konya, long title that Stefany mentioned. Sorry for that. It's got too many words in it. Basically, my job is to be an advocate on behalf of innovation communities like the one that you're trying to build there and grow there in New Mexico and in many other regions as well. We do this for two reasons. One is for me to be able to understand the pain points and friction points in the healthcare innovation ecosystems, what's holding back the pace and scale of adoption of new emerging technologies in healthcare, which is then obviously limiting our ability to leverage those technologies to drive down costs, to improve care, to improve quality and outcomes, patient experience, clinician experience, administrative efficiencies, all those other things that we want to try to take advantage of, like other sectors outside of healthcare, with the use of new technologies. Now, the way that we've done this in the U.S. is over the past 20 years, we've been focused on laying a national infrastructure or framework for digital adoption. You go back to the early days of the mid to early 2000s, healthcare information was largely still all on paper, manila folders, filing cabinets. And to this day, there are still some outlier settings, especially in certain community-based settings, where you still can experience that. But for the most part, over the course of the HITECH Act investments in 2009, with the Meaningful Use Program and billions of dollars partnering with CMS to spur the adoption of electronic health records, we moved from having less than 10% being in a digital format to today being less than 10% is in a paper format. In fact, I'd say less than 2% in most traditional settings is in a paper format. It's almost all digital now at this point. Still a few last mile places to go, but still, making progress towards that. In 2016 was our next major piece of landmark legislation that really helped plug some of the gaps around the interoperability challenges. Because what happened between those years was, while we did support a lot of adoption of this digital infrastructure, we still had a lot of silos of that data and information. So we weren't really fully in a position to take advantage of all that data and put it to good use. Certainly weren't in a good position to use that data to fuel next generation development of digital tools, including what we're trying to support nowadays with the advent of next generation AI-related tools. But it was with the Cures Act that we were able to start to focus on how to prevent information blocking, to unlock that data, to fuel more innovation, and to increase good governance practices around how to use all this interoperable information and data in this country. And we see that as being really kind of the train tracks that have been laid now for everything else to ride on top of. When we have agentic AI tools being deployed, whether for administrative purposes or for clinical purposes or for new drug discovery, because of the investments we made over the last 20 years, we're really in a great position as a country now to rapidly deploy these tools and solutions with the right collaborations and networks in place. Currently, our latest priorities, just wanted to highlight this under this administration, is to simplify it at a very high level, is to focus in these three key areas. One is using all this interoperable information, digital adoption to increase access to care and affordability of care, things that we know we're still challenged with in the U.S. health ecosystem. To improve more data liquidity, because again, there's still a lot of business practice challenges around sharing of data, as well as still some remaining technical challenges of some outlier organizations that weren't part of the early stage and meaningful use adoption. And then to support our ability to take advantage of technology evolution. Typically, healthcare is way behind many other sectors in its adoption and exploration of use of technologies, things like digital twins, et cetera. And so we want to continue to make sure that we're well positioned to take advantage of these new emerging technologies, the sooner the better. The way that we've done this, both over the past 20 years and into the future, is through coordination. And that's what the Office of the National Coordinator for Health IT is really all about. We consider it the big C in the ONC. We do this through a lot of standards development, certification of EHR vendors to set that minimal floor for technological interoperability and data capture, sharing, et cetera, minimal functionality for these health IT systems, and then to support greater exchange across all these environments. And that coordination not only happens internally across all the federal agencies, and I have a slide to show you exactly the breadth of that level of coordination, which is a task in itself, but also, and I think more importantly, with those outside of the federal government, with many of the folks like you in the room on this webinar today, and in the communities throughout the country that are trying to support innovation. On the federal side, we do it primarily through the Federal Health IT Coordinating Council, an internal coordinating body that spans 40 federal agencies. On the right-hand side, you see all the traditional agencies that you might think of underneath the HHS umbrella being associated with healthcare and human services. The youngest being ARPA-H is one of those transformational innovation fueling types of organizations. The FDA is a heavy regulator. CMS is one of the largest payers in the world, if not the largest payer. NIH, one of the largest research institutions in the world, and the CDC, looking at our public health prevention practices. On the other side, though, you probably don't realize there's just as many agencies that we coordinate with outside of HHS that have something to do with healthcare data or healthcare technology. The example I love to highlight, if you've heard me speak before, and you're probably hearing it again, and I apologize, is the United States Postal Service. In the US, we don't have a national patient identifier. There's reasons for that. And I can't get into that, but I can tell you that the way that we do it is based on probabilistic matching to make sure that this John Smith is the same in this health system as that John Smith that's in maybe an ambulatory setting. And to match those records, we have to rely upon taking a couple of key data elements, matching them up, and determining whether or not that is that individual, address specification being one of those. And that's why we work with the United States Postal Service to have address specification mapped out for the healthcare industry. But the other thing that a lot of people don't know about us, for those who have worked with us and understand our general role in the federal landscape and working with industry, is that in our duties under that High-Tech Act back in 2000, in the mid-2000s, was really also focused on promoting a more effective marketplace and greater competition. And I think that's a pretty awesome, large-scale responsibility. It's a pretty broad responsibility I have on our shoulders. And the only way we can do this is not only work with our federal partners in coordinating in a better manner, but also specifically working with, and I'd say even better, empowering innovators like all of you in the New Mexico region and beyond to take advantage of this. So that brings me to the point around cultivating innovation ecosystems, something that I've been working on and extremely passionate about for the past 20 years across a couple of different roles that I've had. In state government, it was all about building innovation ecosystems in Illinois, and this is again the mid to 2000s to early 2010s, and studying what makes an innovation ecosystem unique and how can you grow it and strengthen it to get a greater level of both innovation output, and at the time I was also very concerned with economic output, job creation, job retention, new value creation out of these new products and services in the marketplace. If you think about in the healthcare specific innovation ecosystem or health IT innovation community, as I like to focus on within my current role, we look at who are those types of stakeholders, and hopefully everybody on this call can see themselves as falling into one of these four main categories. Those early adopters who are implementing and testing emerging technologies and novel approaches. So if you don't have those individuals willing to champion and bring these things into the right settings and to further validate them and prove them out, get the evidence necessary to get funding or contracts and commercialization, then it doesn't work. Entrepreneurs and developers who build these technologies and bring it to market. And when I say developers, it's not just independent developers, but those within a large health system or those within a large big tech company, again, who are bringing these novel solutions and technologies to market and trying to, with the support of those in category one. Number three is investors, those who financially support the other two categories above, and figuring out how to give them the necessary resources to scale and meet the demand and bring those ideas to market. And then finally, what I call like my catch-all bucket, incubators, accelerators, boot camps, associations, and membership networks. These are those who really provide the places, the spaces, the opportunities, the clarity in the marketplace, the access, who's doing what, where, all of that. And then sometimes even technical assistance to help people that are in those first three categories be more efficient and again, bring those ideas to market faster. I'm sorry. Now, from the government side, we think about this, and I think industry does in many ways as well, is how can we support these innovators at the right stage with the right level of resources and engagement strategies? Stage one being that early ideation, pre-seed, how do you get it just to, proving out a great idea? And there's a lot of different ways that we fund and support and engage in innovators at that space. The next stage being development support, and this is how do you actually build, test, evaluate, iterate, and validate, to ultimately get it ready with the evidence necessary for the final stage being commercialization. Now, I'd argue in the past, we've done a lot of focus on the federal side in supporting stages 1 and 2, and some governments at a state and local level also, with not enough work on the third stage. But I will say in recent years, we are trying to figure out how to better support that and had some examples of how we're doing it. The other thing to think about is when we are supporting in each one of these stages is to think about exactly the smooth handoff between these stages and the role that we need to play supporting and working with many organizations like Builders VC and HealthInno, and what you're doing with Health ImpACT to help people evolve from stage 1 to stage 2 to stage 3 and to make it as smooth and warm of a handoff and easy to navigate as possible. The other thing, again, bringing back to our point around data, we understand that data plays an extremely valuable role in every one of these stages, and we need to make sure that data is being made available, organized, analyzed, accessible to help fuel innovation at every one of these stages as well. So I encourage both what we're doing on the federal level to continue and for you to engage in that, but also to think about what you can do in addition to that in your local ecosystem. Now, when I say an innovation ecosystem, some of you may not have an idea of exactly what I mean by that, or you might get it confused with some other terminology, and I'll cover that in a second. Number one is just in general, it's describing this role about all these different factors or entities working together within a certain area that can enable entrepreneurs and allow that innovation to occur in a sustained way within that particular location. The sustainability part is something that I encourage you to think about very intently as you're building this and growing this ecosystem in the coming years. How can you set it up so it's bulletproof against changing dynamics, including things like the pandemic that we had just a few years ago? We did see in several other innovation ecosystems that some of the investments that they made previously that were too heavily dependent on one stakeholder, providing the resources or the space for that when the pandemic hit and those resources got tighter, that individual or that organization could not sustain maintaining that asset for the region to take advantage of, and we saw it go away and not come back since then. Others pivoted or had such a diversified approach to how to support those types of resources that they did survive and come out on the other end, still supporting the regional ecosystem. But by having these all organized and being able to analyze how they're developed differently in different regions and markets, it does help policymakers like myself and others at the federal level, as well as those at a state and local level, and other business leaders as well within that ecosystem, understand how we can provide a more supportive environment for their success. So now, if you're familiar with an innovation spectrum, the idea is on the left-hand side here, in the early discovery research phase, you've got a certain level of traditional investment made available, academia, government, et cetera, and that gets it only so far. And it's really when small businesses come in to try to create IP around that and bring it to market, as they're further proving out the technology development and demonstration, that's where they run into the biggest lack of coordination and efficiency and deployment of resources, that then sometimes leads to companies not being able to make it across that valley of death and make it something that's not investable or commercializable. So the challenge is how can we make those resources in the front end carry as far as we can and bring some people from the right end, the industry and investors, in earlier with a more coordinated effort. Well, part of how you do it is you have to map out what are all the assets in your ecosystem that you can tap into and understand who has what to contribute in helping companies get across that valley of death. And so by getting a good map of all these regional assets in these classes, it gives you a really good sense of who can be leveraged to help support which companies at which stage in which ways, and you're not wasting anybody's time or limited resources in that journey, especially within that local region. This becomes known as the championship effect. Essentially, what happens with the more clear, defined innovation ecosystem with all parties working together in perfect harmony and making the maximized use of all the limited resources available to support innovation, you have both those resources on the left end extending further into that cycle, as well as that risk mitigation shift where it's more comfortable for investors to come in earlier because ideas are further coordinated and validated at an earlier phase. And that has this effect of shallowing that basin, that challenge basin, and making it easier for startups to cross that valley of death. Another way to think about it is if you have a symphony orchestra in any of your cities, one way to think about it is how an orchestra works together. Sure, it's possible for any one of those sections to produce beautiful music on its own, i.e. innovation. And sure, you can create some unique sounds and appreciate that. But only when is it working in perfect harmony together, playing from the same sheet of music, can you create something truly magical and something much bigger than the sum of all its parts on its own. So think of yourself as being a contributor to a broader sheet of music in this case, and how you can play your part in the overall ecosystem and be perfectly fit into the right stage of that sheet of music at the right point to make it all sound beautiful is what you should think about. One quick clarification, if we think about the differences in an ecosystem and some other words that are often thrown around in the same terminology, as you mature in your ecosystem, you're going to understand the differences in these. And also, it's good to understand where do you think you currently sit along the spectrum to help you understand how to get to the optimal stage on the far right. On the left-hand side, you have an innovation hub. This can be one entity, maybe a few, mostly working in silos, just spinning out a ton of innovation. And nationally or internationally, you could be known as an innovation hub for fill in the blank, whatever it may be. But again, it could be one company or one organization or one research institution that's doing all the work of spinning out that innovation. Not really, it's just a hub for activity, but not necessarily really a cluster or an ecosystem. In the center, which is going to create a slightly more amount of output of innovation, is when you get to a cluster point. This is where you've been able to identify several different innovation actors that are churning out innovation, some level of coordination perhaps, maybe not. But really it's a cluster where the identity of that region can be that you have many different organizations churning out innovation in that area, or sometimes many different types of areas of innovation occurring. So maybe you're specializing in drone technology innovation, as well as quantum innovation, as well as healthcare, whatever it may be. So you could be a cluster of innovation with either of these different actors and or different sectors that are coming out of it. But again, minimal coordination, not really fully realizing the opportunity that you have to create even more and have a better identity. So the optimal state is then going to be on this far right. Perfect harmony, working together across all institutions, knowing who has what resources to contribute where, and making the most efficient deployment of all that coordination and resources. Really, truly working together in harmony as an ecosystem, similar to a biological innovation ecosystem where the built environment and living environment, or the biotic and abiotic factors, are working together to sustain life. In this case, you have the best shot of sustaining life for innovation if you're all working together in perfect harmony. Not sure what else is. So as you're building this, something to consider, and there's a couple different books out there, but step one, just map what you have. I know that Angelica and Stefany and others have been working on this and have a good amount of it mapped, but I encourage you to go a layer deeper, continue to try to map this out and get as specific as you can in as many areas, and then figure out, once you have them mapped, how do you bring them together and get them comfortable working with each other towards a greater goal, not working in their own silos. Number two is understanding that after you have this all mapped out and you understand what you're really good at and what you're not, what makes you unique compared to others? Is there something that you can herald as being the best at, or one of the fastest growing in, or raising the significant amount of investment for, or having the most breakthroughs in? Does it have overlap with multi-sectors where you have this unique intersection between these two, like space innovation and health innovation, and maybe space health, for example? What lies beneath that surface that, if unleashed, could completely change the trajectory of your ecosystem? Are there hidden secrets that nobody really talks about or understands, the type of potential that you have in your ecosystem that is unique compared to other regions? And then lastly is, again, the startups, the corporations, universities, investors, others, how do you bring them all to the table in a safe space way to all see the value of working together and making the most efficient use of their resources? It's kind of the rising tide raises all ships type of mentality. And it's valuable to have them all at this table, not only for their own sake, but also because each one has a different perspective they bring to the table that can help you identify where there's weaknesses or strengths and opportunities to take advantage of. A quick checklist for you to think about as you're looking at your potential is, do you have the capital necessary? And if you don't have it locally, how you grow it, incentivize it to be developed, or even pull it in from other regions? Do you have the connectivity? Coming together through events like this and communities like this is a great start. Are there more defined ways you can keep people connected and working, specifically catalyzing them through different projects or calls to action? Do you have the right culture and mindset, the entrepreneurial, superior can-do type of attitude that you need? Do you have that? If not, how can you build that? The density. And this density doesn't have to be specific to one city. It could be a corridor. It could be the state as a whole. But thinking through, again, is there enough of the assets and resources in a certain area, and have you brought them all together in order to support and sustain innovation around that? The specialization I already talked about as well. And then talent. This is one that often overlook, and many other regions have done a great job of identifying as a risk to future growth and innovation, not only on the startup side, but also on the big tech company, healthcare employer side, as well as, do they have the right level of talent able to adopt these new technologies and innovations and to bring them to market? And if not, how do you work with your academic partners, community college networks, vocational networks, et cetera? How do you recruit them in from out of state? But how do you have the right talent and workforce in order to support and fuel innovation? So with that, I wanted to do a little bit of a round robin here, kind of a chat roulette variation, if anybody wants to hop into the chat and pick their city of choice. But I can talk about some of the successful approaches and cautionary tales from a number of different cities. I've thrown up, 12 or so here that some would probably have an idea, maybe some that they wouldn't. And I'm open to, if others want to ask about other cities. One thing I get to do is work with a number of cities and regions throughout the country through something I launched in 2017 called Together Health. Luckily, Angelica and Stefany are part of that, representing your region as well. But it allows us to look at what makes these different cities unique. And I've seen their journey and growth over the years and their successes and their failures. So I can certainly get the ball rolling here, but happy to, before I wrap this up.
We do have the first ask is Houston.
Houston. Okay. Well, I am currently in Austin, Texas, not too far from Houston. And on the healthcare side, they're probably one of the more well-coordinated and efficient innovation ecosystems, the structure and how they partner together. And there's a couple of reasons for this. One is they're very fortunate to have invested in and built something called the Texas Medical Center. It's a big, large innovation ecosystem and campus that supports dozens, if not more, independent healthcare systems that are all either on a similar campus or part of the broader network. So you can visit and connect through Texas Medical Center if you go to their website, and you'll see they are really a introduction into the broader healthcare innovation ecosystem. You have the largest children's hospital in the world. You have the largest cancer center with MD Anderson, Texas Children's and MD Anderson, that are both part of Texas Medical Center. You've got Houston Methodist, one of our colleagues who's going to be coming up shortly in the next panel, and many other organizations that are really tapped into it. The state has also gone out and funded and secured, working with these other partners, things like the development of Helix Park, which is not far from there. And even downtown, there's been a lot of collaboration with a number of institutions, including Rice University and others, on building out the ION, an innovation incubator space right in the downtown heart of Houston that also has support for things in the manufacturing or maker lab space and a number of other things. They run a lot of challenge competitions, have a ton of events, have relationships with international markets, including in South America and Asia, and really do have a pretty well-developed, cohesive ecosystem. If I have somebody I know who's visiting Houston to meet with one stakeholder, whether it be a startup or an investor or a federal policymaker like myself, I'm able to connect them with Texas Medical Center staff and a number of other connections and get them introductions, and they usually will come away with a ton of tours and meetings and able to navigate them very easily. And you can find a lot of this information online pretty easily as well that tell the story of the strengths of Houston. So that's my high level of it. There's always room for improvement, obviously, but I've seen out of them that there is a commitment both from their industry stakeholders, their health systems, their big tech companies, others, as well as the state and local government to really work on continually building and growing that ecosystem. What else do we have? Do we have any others in there, or should I jump in?
Yeah, we've got Denver.
And San Diego.
Denver, okay.
2%.
Denver and San. Yeah, so yeah, and I see these are people who are coming from these other cities as well. So Denver, let's start with Denver. Again, you're going to get, luckily, I know we have a colleague from Denver who represents one of the ecosystem champions that really is a safe space for bringing together their ecosystem, which is Prime Health. And I've worked with them for years, and they're a prime example, pun intended, of how to have different types of elements to keep your innovation ecosystem going through challenges like the pandemic. When Catalyst HTI was built, it was this massive building, 4 blocks around, multi-story, and it was meant to be the hub of digital health innovation, healthcare innovation for the region. Filled up, from a leasing standpoint, would have events and all of that. And when the pandemic hit, became very challenging to maintain tenants in that facility, which means a lot of the events and other activities kind of went away. From what I understand now, there's not necessarily a healthcare identity there anymore. There are still some companies there that are healthcare related, but it's lost a lot of its mojo in that sense as far as being purely healthcare focused. I have no doubt they're going to continue to reinvent themselves and find other ways of supporting the ecosystem, and potentially it does come back to the Catalyst HCI space. But across all this time, Prime Health continues to run their annual innovation challenge and summit. And it's that once a year opportunity to bring together not only their whole local ecosystem and regional ecosystem, but also innovators from outside of the region, investors, customers, you name it, policymakers like myself, to engage and hear all the stories about what they offer in that region. And not to mention that it has historically been a great collaboration event for the state's Office of E-Health Innovation to come and engage with and set state policy for how to support healthcare innovation and e-health adoption in their state. And they've used it also to tackle specific issues for their state, such as rural health needs, behavioral and community health needs as well. And they've really created an identity for themselves as far as being an innovator around those spaces because of the number of interactions and coordinations with all those stakeholders that specialize in those areas. So that's just a little bit of my high-level assessment of Denver. But Denver and even San Diego were 2 early ones that when I was in Chicago in the mid-2000s, where they were growing a startup ecosystem, not specific to healthcare, but just in general. And we were looking at some of the unique things that set the conditions for them to grow their innovation ecosystem for entrepreneurship. And a lot of those things still maintain in both of those communities today. Did you say, was there another one?
Well, we're actually at time, and Stefan, I know you could talk for
Okay.
probably 8 hours straight on this, which is a great segue because we are excited to welcome Stefan back in October for our annual Health Innovation Summit on October 8th. You'll hear more about it. Where hopefully we can dive into some of these in a little bit more detail, and we're hoping to organize some roundtables and things like that with folks. So if you're interested in that, let us know. But otherwise, thank you so much, Stefan. We have really appreciated this, and I'm sure we have more questions than answers at this point that we'll get to you.
No worries. Thank you so much. Really excited for what you guys are building there, continuing, to work with you in the future. And hopefully I can make it back when you have your event in person later this year. Hopefully it won't be in conflict with something else.
Yeah.
But
Yes.
best of luck to you the rest of the day. And I'm excited to listen in on the panel coming up with your colleagues from, both Roberta and Keisuke.
Awesome. Well, with that, thank you so much for the segue. All right. Well, with that, I would like to welcome Dr. Keisuke Nakagawa and Ms. Roberta Schwartz. Dr. K joins us from the UC San Diego Health's Jacobs Center for Health Innovation, and Ms. Schwartz joins us from Houston Methodist as EVP and Chief Innovation Officer. So we will be having a panel today that I will be moderating. And let me just get these timers situated while our panelists come to light here. All right, so, well, I don't know, timer's not working, so we're just gonna go with it. Dr. K, Roberta, how are y'all doing today?
Doing great. Thanks for having me.
Great. Okay, awesome. All right, well, let me stop share so we can spotlight. I would love to get started to hear from both of you. Just, tell us a little bit about your role, your background, and I would love to hear, just in one sentence or two, how did your innovation center get started? Roberta, we'll start with you since you were on first today.
Oh, you're so sweet. It's only because I got the time wrong. So don't worry about it. So I'm Roberta Schwartz. I'm the Executive Vice President and Chief Innovation Officer from Houston Methodist Hospital. One of the I hold this very odd role in that I run our academic medical center and I run the innovation activities for our 8-hospital system. And it's 8 hospitals. We serve 7 million people. So if you look at the population, it kind of almost equivocal to the kind of a lot of different states. So it's a big ecosystem that we get the opportunity to play in. Our Center for Innovation, Methodist has always been innovative, but in the digital innovation space, kind of got very focused about 8 years ago. Started from, I wear it on my sleeve, called DIOP, the Digital Innovation Obsessed People Group, which was kind of a group of individuals who got together really more on a grassroots level and spoke about how we felt like this could really disrupt and turn our healthcare system and really disrupt ourselves from the inside out. That group began with a succeed fast, fail fast kind of mentality with a very small amount of dollars that we really did get started. Now, if you really look at our ecosystem, we play in every area of the organization because, as we always say, every aspect of healthcare is pretty much broken. And nothing is easy about healthcare. So we play in everything from access and registration and scheduling to, the way physicians are going to interact and like ambient voice. We're going to play in the revenue cycle, in supply chain costs, in every different aspect, and kind of move through these different areas one by one, in the order at which the technologies are really ready and affordable, and kind of work through the change management and the difficulties of really changing from the inside out. So we have a partnership model. We work with a lot of different companies and have the opportunities to know a lot of innovators in the field. I'll stop there.
Thank you. Dr. K?
Sure. No, thanks. I really appreciated Stefan's earlier comments around like the large scale ecosystem. And, Roberta, I was actually at, Houston Methodist about 5 months ago learning about your physiologic monitoring program. And so, it's so amazing to see, New Mexico and HealthInno really doing this because it really, innovation is so collaborative now. we really need to be working together, and different health systems are, really focusing on certain areas and that really are, best in nation. And I think there's a very great opportunity to be a larger kind of national fabric around innovation that we're sharing these best practices. So, Kei Nakagawa, I'm Director of Strategic Impact and Growth at the Jacob Center for Health Innovation at UCSD Health. So Jacob Center for Health Innovation is the clinical test bed in the innovation group for the health system. And so I leverage, I'm a physician by background, also did a fair bit of health policy on the Affordable Care Act and High Tech Act. And so I try to bring a lot of these different kind of lenses to how does innovation become a sustainable function for a health system. And for us as an academic medical center, we really want to be able to create a resilient, sustainable team and function of innovation, because innovation has a lot of waves and trends, right? Like, so it was digital front door, RPM, now it's AI. And oftentimes, innovation groups get spun up to address a certain technological trend. But really, as a relatively large academic medical center, we really have been innovating from day one, and innovation is part of our core DNA. But that doesn't always mean that there's a very clear business plan for innovation, right? And so that's really where I work on and lead strategic partnerships, business strategy, and business development, as well as new ventures and strategic initiatives, because we really need to be having almost our own startup mindset when we create a innovation group. And a lot of it does come around to diversified revenue streams, to have long-term resilience, really partnering with industry so that they actually can bring their strengths, which I think is much more around product and go to market. And we can then complement that with know-how exchange, de-risking technologies with more product market fit insights. So there's such a valuable and synergistic partnership between, I think, health systems and industry. And so we're really trying to focus our strategy very much around that type of model.
Thank you.
Oh yes,
Okay.
and one last your question around like how we got started. So we were very fortunate to have Dr. Erwin Jacobs be the initial kind of seed investor donor, right, to get us kickstarted. But that really allowed us to again build a team. We actually built an entire kind of facility for our headquarters for the Jacob Center for Health Innovation, and as we kind of reach the end of that kind of gift milestone, we've been working on a chassis that actually is sustainable and can, continue to deliver value over many, many years. And so I'll pass it back to you, Stefany, but that's kind of a summary of what we do here.
Yeah, that was great. And just for the audience's sake, know that we did invite these folks because we have one perspective from an academic health center and an innovation center that's sort of embedded, and then one that's a little bit more on the faith-based private industry side. And so I'm interested to kind of hear the similarities and differences there. But first, I kind of want to set the stage. So we're hearing from two very advanced health systems in terms of their innovation, both ecosystems, as Stefan said, and advanced innovation models within your own health system. And so I wanted to preface that there's a spectrum, or I consider it a spectrum, for how healthcare organizations of all types can approach innovation. So, at the smallest, simplest, not so simple side is, running pilots and starting to dip your toe and starting to try new things. And then we see people moving along that spectrum of innovation maturity or whatnot to possibly say co-developing bespoke solutions, maybe alongside innovators, or partnering with startups and saying, we'll co-develop some shared IP or maybe even some shared ownership and develop something not only that works for us, but others. And then we have, a little bit further along, which I think some of you are touching on here, is, direct incubation of brand new nascent seed ideas, and then possibly even on the farthest end, venture-like investments, whether that's directly into the company or venture investment into funds. So I wanted to set that spectrum for the audience. And I'm curious, I'd love to hear from each of you where in that model or that spectrum that your organization sits. And most importantly, what advice would you give for a healthcare organization who's sitting in the audience, just kind of wondering like what all this means or what's right for them? And I'll open that to whomever, wants to pop in with that first.
I'll be happy to start. It's such an interesting time period for different organizations. And one of the things that I love is the fact that a lot of things are priced, whether it's per bed, per encounter, per compute power, which allow people of different sizes to get involved in all the different kind of innovations. In addition, now with agents that you can build within Microsoft, within Amazon, which within, all kinds of different applications, there are small issues that you can solve. I call them paper cuts that could be solved with small agentic coding within your organizations, right? People are saying, oh, I vibe coded something over the weekend. And you can do this with fairly small numbers of people. So can you do everything that Houston Methodist is doing? No, right? You can't do that as a smaller healthcare organization. Can you stand up an entire remote monitoring unit, put cameras in every one of your rooms? No. Can you buy two carts and link them to the university hospital and basically build off the infrastructure that exists somewhere and basically tether to it? The answer is absolutely. So you have to really decide what you can solve and build on your own, whether that's an easier way for people to document or easier way for people to order meds or get information about infectious diseases or whatever it is, right? Open evidence is very free for your doctors, right? You have to accept the fact that it's going to be advertising. They're selling the information to advertising, but it is a much cheaper, free way to get up to date kind of thing than it was before. So you have to look for those opportunities, right? Can you get all translation services? No, but can you get a lot of them via AI? Absolutely. Right? You want to maximize those things for the different technologies that you're already paying for and look for alternatives that make it inexpensive to add those on to what you're doing already. So I do think it's an interesting time where you can't boil the ocean. You can't do everything, but there's an awful lot that you can do.
Yeah. Dr. K, anything to add to that?
Yeah, I think this is a really great question because when I do agree that on one level, like the spectrum is okay, if you're co-developing, you have a venture fund, you have a lot of industry partnerships, all of that defines you as mature on the innovation spectrum. But I actually think there's a lot of different spectrums to consider when you are thinking about what innovation is, right? And I always think of innovation ultimately as, are you driving impact at scale in your communities? It doesn't have to be millions of patients, but in your area, are you actually driving, invention plus adoption to drive scalable impact? And I think a lot of organizations that may not traditionally consider themselves innovative on kind of the more Silicon Valley definition of innovative, right, are actually quite innovative. So, one of the projects I worked at UC Davis Health in Sacramento, I launched and led their innovation group for about 5 years. We worked with a lot of FQHCs, the Sacramento County Jail to address recidivism. And I learned so much from our FQHC partner in terms of how their case managers were going out to homeless encampments to identify their patients. How are they doing, patient engagement at a level that really addresses like SDOH, right? And I think those things are extremely innovative, in my opinion, right? And so when we think about innovation, I do think it's natural to like index on digital AI. What's the latest technologies? But for me, it's really like, do you actually understand the problem? And do you actually understand it at a deep enough level where you can pick the right technology to accelerate the improvement of that problem, right? And in that level, I think we actually really need to think of everyone as being innovative, right? In terms of how they're solving problems and learn together. And especially though, as Roberta mentioned, we are, I think, in a very important inflection point with healthcare and healthcare technology where, if you think about like when I worked on like the High Tech Act, it's like almost nobody had EMRs, and that was only about 15 years ago, right? And then, technology became EMR equals technology, and IT departments equaled, a group that supported the EMR. And then we built on that to start to think about other software and RPM and digital front door, all these things, right? Now, I think that we are at a point where technology is getting pretty commoditized, right? And it's really like how we use the technology to drive impact that is, I think, the core of innovation, right? And it doesn't mean you don't really need a venture fund or an industry partnership to actually be innovative, right? So I think that there's a lot of opportunity for us to almost like redefine what the right spectrum of innovation is that is actually a lot more inclusive in terms of everybody being able to share their insights and create playbooks that anybody can use. So, that I think there's a lot of work we still need to do around even kind of defining together what innovation really means in the context of healthcare.
Yeah, I love it. And I love that you're both also alluding to this innovation mindset. That's more of also a culture shift, not just a technology dropped in and all of a sudden we're innovative and we think everyone's going to use it, which everyone here on this call will tell us to get out of here. So great. Okay, I'm actually going to slip in. We had a great question from Dr. Epstein in the audience. I'm going to slip this in and mix up our next question a little bit, if you all will bear with me here. But I think for you, Roberta, I'll start in with this. So larger health systems are often very risk averse, of course, healthcare as a whole even, capital constrained and margin oriented. How do you make innovation fail? Oh, how do you make innovation and or fail fast work in these settings?
Yeah, it's really interesting. We have a very good philosophy, which we always joke, if the vendor won't follow by it, we won't sign up with them, which is that we always leave ourselves an out to kind of trial things, assuming it will succeed, but knowing that it may not. And so if a vendor won't sign up to give us an out, we walk away from the vendor. It's just kind of philosophically where we stand. And if vendors really believe in what they're selling to us, then they will stand by it. The second part of it is that when you assume it will succeed, the hardest part is getting kind of in that ITQ to really get everything integrated, because a swivel chair can only work in so many different ways. So that's why you can't attack everything, right? This is a big year for us in imaging. We're doing a huge amount in imaging AI this year. This is our imaging AI year. People have said, like, can't you take on Path or can't you take on this? And the answer is we can do incremental projects, but we do need some focus, right? We have 4 or 5 things that we're going to take on in a particular year, and then the other ones we're maturing at the same time. So, as we're doing it, we recognize like big, in the innovation space, it's that old adage, right? You have the rocks, you have the sand, you have you have the water, and you can fit in a bunch of water, but you can only fit in so many boulders. And so when you look at the innovation space, you have to make decisions. We don't have a roadmap because, again, different things will mature. All of a sudden, someone walks up with an incredible malnutrition solution and you're like, oh my God, I can fit that in. That's, some sand. And that'll have a great ROI and a quick ROI and doesn't require, a huge amount of work. Some things can be done and don't need a huge amount of integration. Great, fit them in. But when you decide like this is the time, this is the space, this is the maturity, you're gonna get, you recognize the tech. And I say this all the time, it's probably my most common phrase. Tech is 25% of the problem. 75% is the change management. It is 75%. If 75% is the change management, you have to understand how much your organizations can absorb on the change management level and which part of the organizations can absorb that. Maybe access can handle it, but med records can't. Maybe revenue cycle is ready, but the physicians in endocrinology, where you're adding something in and basically doing a virtual triage model, it is not ready. And so if you need to push through all of these things in change management, it becomes about the decisions. It becomes about strategically calling it at the front end, saying tech's ready, I think I can push through this one. Doctors pretend that they're ready. I can tell you every single time. The doctors say to me that they're ready, or the staff say to me that they're ready. They immediately, what I call, do a recoil. They get really excited. You go to the kickoff meeting, everyone's really psyched. They basically get in the room, they're all jumping up and down. And then about an hour later, you get a recoil and they attempt to throw you out and throw out the tech and discredit everything. And you have to just say, no, we're going to get back in the room. We're doing this. You guys said we were going to do it. We're doing it. Like we're doing it until we prove it fails. Not because you think it may, not because you don't like the concept. Until we prove it fails, you're in the room. And when you push past that, right, you generally get to the other side. It's tough, but you can do it.
Yeah. So I'm hearing themes of leadership buy-in and strong and leadership will as well. We have about 4 minutes left, and so I did want to parlay that. So Dr. K, you're inside an academic health center, so arguably there's more research infrastructure, tech transfer incentives, faculty incentives have, such as grants and publications that don't maybe, play into some of the things that Roberta is dealing with, but undoubtedly it's its own kind of hard. Maybe the ROI conversation looks a little different. So just quickly, what would you parlay onto what Roberta said there in terms of the pros and cons of innovation AHC or, similar types of constraints?
Yeah, I would say, the culture is really the big thing, right? And so making sure that you have a culture that supports innovation is actually quite hard to do. And so thinking about it from the academic medical center lens, part of that culture is also the structure. So do you have the right incentives to support and drive innovation? And so oftentimes, even at an academic medical center, we actually don't incentivize for scalable innovation, right? Like we incentivize faculty to publish papers. We incentivize to get NIH, NSF, ARPA-H grants. But oftentimes, once you're at the tail end of those cycles, it's actually more incentivized for you to open a new cycle with new ideas, right? So you see a lot of faculty who are heavily invested in a portfolio of innovative ideas, but not necessarily committing to then take that all the way to like a startup that can then ultimately scale to other customers. So even as an AMC, we have amazing faculty, really strong ideas, but it's really comes down to like the incentive structure, even for us. Are we actually incentivizing our staff and faculty to innovate beyond the R1 grant into an SBIR, into commercializable products, or are we structuring these innovation projects where there is an industry partner that can actually take that, and being able to take that to the rest of the market, and we're just focused on de-risking and accelerating that process to product market fit, right? So I do think that we have a lot of resources. I'm very lucky to have such forward-thinking, innovative faculty, but it still needs to have the right structure and culture for us to be able to kind of make that ultimate impact.
Awesome. Well, I feel like we could all talk for many, many more minutes, but we have a 30-second challenge to close us out for each. So what is the one single most important piece of advice that you would give to a healthcare leader sitting in the room who's just beginning to think about where innovation fits in their roadmap? Keisuke, since you have the floor, why don't you kick us off?
I would say a very clear, focused North Star. Everyone can understand and align to, because innovation can distract you in many different directions. So having that focused discipline and a clear North Star can really align the entire organization.
Awesome. And Roberta?
Yeah, similarly, innovation is one of those things that's like picking up a log and like a million things crawl out and like you're so distracted and so crazy that you can get schizophrenic very, very quickly. The answer is start small. Like start small and do one project and then build on the next project and build on the next project. And just be calm when everyone shoots different ideas at you and different things. Just keep moving slowly one at a time. And when you turn around and look back, you'll be like, oh my God, look at all the things we did.
I love it. Thank you guys both so very much. Big round of applause. With that, we'll be moving on to our next speakers. Thank you so much for joining us.
Thanks.
Did we lose you?
All right, thank you, Steph. We'll now shift into our first showcase segment. Built here, New Mexico founders are already solving healthcare's hardest problems. This segment features some truly innovative companies from New Mexico who are already doing hard work to help address unique challenges, opportunities here in the region and beyond. This is just the sliver of health being built in New Mexico. One of our goals is to help nurture, attract, and grow much more. First up, we'll hear from Othman, Ouenes, CEO and founder of Fidari, who will take the next 10 minutes showcasing his company. Welcome, Othman.
Hey everyone, this is Othman. I'm going to share my screen here if you guys don't mind just being a little patient. Give me just a second here.
Perfect.
All right, can everyone see my screen here?
You bet.
Great. I'll get us started here. Good afternoon, everyone. I'm Othman Ouenes. I'm founder and CEO of Fidari, based here in New Mexico, as Joseph explained. Joseph, thanks for the intro. Stefany, thanks for running this wonderful virtual summit. What we do, we build infrastructure for navigation programs, and we're starting on oncology. The goal for the next 5 minutes is to show you how we turn navigation departments from cost centers into margin positive and data-centric operations. Here's the problem we solve. So cancer navigation programs run on some of the highest skilled, expensive clinical labors in your building and systems. Nurses, social workers, navigators. Because navigation is a relatively new role in the care ecosystem, they spend most of their day today on manual workflows like scheduling, callbacks, and documentation. Tasks that we believe are far below their training. Meanwhile, the work that they should be doing, sitting with patients, having that conversation, and the reimbursement that comes with it remains invisible to your system. And the patients who fall off therapy do so for reasons that never show up in the EHR. Navigators are the key to this. So here are the important regulatory tailwinds that changes everything as of 2026, just this year. In 2025 and 2026, CMS finalized a new category of billing codes called the Health Equity Services. The headline code is called Principal Illness Navigation, otherwise known as PIN. It was designated for patients with serious illnesses expected to last 3 months or longer. This includes things like cancer, HIV, substance use disorders, patients essentially at high risk of hospitalization or decline. PIN doesn't stand alone, though, as a code. It can now support other codes like CCM, chronic care management. These codes stack together on top of each other. The American Cancer Society just this year released a report that found that less than 10% of the top cancer programs have adopted PIN codes into their navigation workflows. But the codes alone are useless. There are 2 compliance requirements for data collection that now sit on top of the same work. The first side, on the billing side, an initial qualifying provider visit annually, documented patient consent, a certified navigator, time track per patient per month, documentation of visit, physician approval. All this is required to get paid by CMS. Without the documentation, you can't bill PIN or CCM. On the accreditation side, this is also super important. The Commission on Cancer now requires Standard 4.4, a documented patient navigation process, Standard 8.1, a 4-step barrier to care analysis and annual review, and Standard 8.2, psychosocial distress screening, and an annual outcomes report from the Cancer Committee. As of January this year, you can't reuse one report to satisfy multiple standards. Each one needs its own documentation. Same underlying navigation work, 2 regulatory dreams, most programs satisfy neither. This isn't a labor problem. The labor already exists. The bottleneck is documentation, tracking, and workflow. Without infrastructure, you leave Medicare money on the table and risk a COC accreditation. This is exactly what Fidari does. We sit underneath your health system, not next to it. We automate the navigation workflow. We capture the documentation that triggers reimbursement. We meet every CMS requirement automatically. And critically, 100% of that reimbursement routes back to your health system. More importantly, you can now collect data on the full patient journey, everything from the patient's symptoms to social data, like how far they're traveling for their appointments. We're not an outsourced navigation vendor like Solace or Time Care. We are literally the rails underneath your existing navigators, your existing oncologists, or providers in your care model. Other models pull your patients, your data, and your reimbursement out of your system. Fidari keeps all 3 inside. You stay the provider of record. Your data stays inside Epic. Your navigators stay your employees. You bill Medicare, and you keep the revenue. Two value layers compound here. And I want to explain this too, because I think some of the points that some of the previous speakers were making are really important here. As you think about as a system, revenue and data. First, labor productivity. The average capacity gain or employment is enough to avoid hiring an additional navigator FT per site. That's an immediate cost avoidance line your CFO can model on day one. Second, and most importantly, revenue capture. Revenue. When we sell to health systems, the first thing we promise is new lines of revenue. For health systems, large health systems like Ardent and HCA, they're literally sitting on $44 to $22 million in new revenue that they're not capturing today. With PIN and CCM stacked, a typical oncology patient generates around $1,800 per year billed monthly. If you think about that scale across the system, that's a 7-line revenue line. For a program with 500 active oncology patients, that's almost $1 million in material recurring revenue back to your system. Same labor footprint, higher capacity, all reimbursable. We are live in production in several health systems today, over 12,000 patients on the platform. We've signed letters of intent with some of the largest health systems in the country, including Sutter, Northwell, Moffitt Cancer Center, UNC Health, Advent Health, Rutgers, and UT Health Science Center. There are 8 more cancer centers in the active pilot negotiations as well. On the life science side, which we basically monetize the data with our health systems, AstraZeneca selected Fidari as the final winner for the Lung Innovation Challenge. So we have a pathway with working in life sciences. Epic F8 fire integration, SOC 2 compliance, HIPAA compliant, standard go live is in 4 to 6 weeks. Let me just break down the numbers here for everyone here, because a lot of people are probably wondering how this all works. So these are real numbers from our live customer at UNC. This is just 850 new oncology patients per year. 80% qualify for the PIN, 70% enrolled. That gives them 595 enrolled patients across 2 Navigator FTEs. On the revenue side, that's about 1,800 average per patient per year billed monthly. That's PIN stacked with just CCM without multi-condition billing inapplicable. 95% collection rate nets a revenue of over $1.5 million. On the cost side, we actually overestimate. We look at 250,000 for 2 navigators. That's usually very, very on the high side, but we try to be conservative with our estimates. That's total costs are around only $400,000. The net profit per year after 1 year is around $600,000. That's a 60% margin. Each navigator FT generates around $300,000 in net profit, break even at 120 patients per navigator, well below the 297 each is carrying. This is just one site. I really want to emphasize, just one site. For a multi-hospital system in this room, multiply that number by cancer centers in your network and you get much bigger numbers. For the New Mexico systems in the room, this matters specifically, right? So cancer outcomes in the state are tied to access. Rural patients, underserved populations, tribal communities. Navigation is how those patients stay in treatment. We all know that here. PIN was designed exactly for this type of population. The Health Equity Services designation was written for high-risk patients in underserved settings. That is literally New Mexico. Fidari is capturing it operationally feasibly at scale. We turn the work your team is already doing into a documented, reimbursable, measurable program. Moreover, most importantly, we help you collect the richest data set on the patient journey yet, so you can also monetize that data with Fidari. Everything from the clinical side to the social determinants of health. What I'm looking for in this room. So if you run a cancer program, a service line, or an ambulatory operation, your navigators are stretched thin, and you suspect your system is leaving PIN revenue on the table and not thinking about a data strategy, we'd love 20 minutes to talk. We will walk you through what a current navigation program could capture under CCM and PIN, and we'll show you what comparable programs are seeing. No procurement lift to start. There's a demo here. Feel free to click through if you'd like to see a full demo, but feel free to also reach out for any questions. Thank you for the time.
Thank you, Othman. We have a few minutes if you want to take some questions from the audience, but we do have a few minutes before Evan comes on next. So
I'd love to. Any questions?
Yeah, let's start with Dr. Epstein. So why is there not a New Mexico-based health system among the pilots for you? Which is why we are here, but would love to hear from you what the challenges have been.
I'll give let's say like a politically correct answer. And I think it's the systems we've spoken to in New Mexico seem more focused on policy rather than innovation. We've spoken to quite a few, but we haven't been able to penetrate that many, and we haven't had too many connections to other systems in the state. But I would love, I met with the leadership of Ardent. They have a site out here in Loveless. We haven't connected with them yet. I've met with Presbyterian. They love the solution, but they are more focused on other priorities at the moment. So in short, I think innovation is still not a priority for a lot of health systems in New Mexico, from my perspective. But I know HealthInno is changing that, so that's why we're all here.
Barbara, you have your hand up. If you don't mind, could you put it in the chat, or I don't know if you did put a question in the chat.
Yeah, and I think with that, we will actually transition over to Evan from Senior One. Thank you so much, Othman. If you could post your link to the demo that you were talking about. And Dr. McAnany, yes, we'll surface that over to folks, and we're collecting all of the questions that we didn't get to. I think yours probably has a pretty complex conversation to have, so we'll circulate that after.
Thanks
But
so much, Stefany. Thank
thank
you,
you so
everyone.
much, Othman.
Thank you, Othman.
Thank you,
Next,
Joseph.
we'll hear from Evan Thompson, CEO and founder of Senior One. Welcome, Evan.
Cool. Thank you guys for having me. Excited to talk about what Senior One's doing here in New Mexico. So I'll go ahead and share my screen here. Cool. Can you guys all see?
Yep, perfect.
Cool. So my name is Evan Thompson, born and raised here in New Mexico. I'm an ex-pharmacy student here at University of New Mexico. Started Senior One about 36 months ago, and excited to talk about what we're doing here now and the traction that we've made. So Senior One is a transitional care management software. And kind of the secret sauce, or what we believe is the missing layer, is the human component, or what we have as social workers coordinating care between transitions. We are specifically focused on seniors at this time and helping seniors really navigate through the continuum of care and navigate these complex transitions. So this slide just talks a little bit about some of the audiences that we are currently serving here in New Mexico. About 18 months ago, we started with one skilled nursing facility. Today, we have 8 contracted skilled nursing facilities that we are integrated with the EHR and serve as their kind of discharge augmentation or transitional care management partner in helping seniors move through the continuum and make sure that services that they are leaving the skilled facility with actually happen, and that they are not ending back up at the ED or the skilled facility for some of these unnecessary readmissions. We also have a pilot that we've just completed with UNM Hospital that is now moving into a contract where we are focused on transitional care management for seniors who have discharged for the hospital who need help coordinating social determinants of health. So things like transportation, meals, grab bars, things like that. So we are now the partner for UNM Hospital in coordinating those services for seniors who are leaving and discharging from the hospital all throughout the state. And then most recently on the state and local government or local agencies, we have won the RFP, and we are now the contracted care management or care coordination partner for the AAA, which is the Area Agency on Aging, to provide care management solutions for Bernalillo County seniors here in New Mexico, which is really exciting. So now to talk a little bit more about kind of the problem that we're solving here in New Mexico, which is really all about what happens in between these transitions. And I think everyone has stories probably of loved ones, neighbors, family members, et cetera, that have been admitted to the hospital. Something happens at the hospital, but after the hospital, you're kind of you're on your own to navigate this. And that is really what Senior One does and where we specialize in. We have, again, a software that allows us to risk score patients appropriately. And then our follow-up and our social workers have specific activities and motions depending on what that clinical risk is that allow us to cater their care plan to that individual. So we are really focused on kind of what happens in between the gaps after discharge, making sure that folks don't end up back at the ED or back at the hospital. So it's really about that fragmented coordination and then the lack of follow-up that happens after you leave these settings. And I think we've all seen this, but healthcare, of course, became more complex and the care coordination aspect didn't. The days of most folks having straight Medicare and discharging from the skilled nursing facility or the hospital, there being 2 or 3 home health agencies or 1 or 2 durable medical equipment companies that will service that patient, those days are over. So it's a huge lift for discharge planners, social services directors to keep up with the network, to better understand who accepts what insurance, who serves what area. That's what our software does. And again, we feel strongly about that there isn't some point solution that is just AI or just software that it solves this solution. You have to still have that human in the center that serves as that advocate or that care coordination kind of home base. And that's what our social workers do for the patients here in New Mexico. And again, we've seen how higher patient acuities, the Medicare Advantage maze, and the dynamic provider networks have made that really complicated for folks to discharge and get the services that they need. So talking a little bit about our solution, we kind of break it down into 4 primary pillars, which is, again, our licensed social workers that act as the care navigators, our transitional care software, our network intelligence, which is integrated with both Epic and EHRs at the skilled facilities and the hospital that we're contracted with. And then that ongoing follow-up, which we do really consider it lifetime monitoring. So making sure that we're following up with these patients and being more proactive rather than reactive to the services that they may need. So again, those are the 4 primary pillars that Senior One is built on. And talking a little bit about closing the gaps between these care settings. Again, hospital to SNF, SNF to home, home to your primary care physician, or home to senior living. These are all the gaps that Senior One currently kind of serves in. And what we, again, consider our secret sauce is the social workers or the care navigators, making sure that these transitions happen successfully, and that we are in the middle of all of these different transitions. Visibility beyond the point of discharge. I've talked a little bit about when folks leave the hospital or leave the skilled nursing facilities, so many folks fall through the cracks. And that's what our software is really helping these skilled facilities and hospitals do now, is giving complete visibility into the patient journey after discharge. So through our software and through our social workers, we're able to track the readmission rate, time to start of care, the number of services coordinated. We're collecting a lot of patient satisfaction data for these skilled facilities specifically, which allow us to get ahead of potential complaints, F-tags, IJs, those kinds of things, which we've been able to prove in our pilot with these skilled facilities. And then again, acting as that ongoing follow-up or kind of home base for these patients when they leave the buildings, making sure that they're not going back to the ED because they didn't know where to get a prescription refilled and they went to the ED because that was their only solution. Again, by being proactive with our kind of social work follow-up, we're preventing a lot of these unnecessary readmissions. So again, Evan Thompson, we were launched here in New Mexico, started with 1 skilled facility about 36 months ago. We're now contracted with 8 different skilled nursing facilities, 1 hospital system, and then the AAA, the Area Agency on Aging here in New Mexico, serving specifically seniors through these transitions. So maybe I'll stop there and want to make sure that if there's any questions, I can answer anything that any folks might have.
Thank you, Evan.
Evan. We have time for maybe about 1 question. Okay, it looks like we're all still chitter-chattering about the misaligned payment incentives in the chat. So this has been awesome. I can say, Evan, this is obviously a huge issue that we hear from a lot of our hospitals across the state in terms of complex discharges, burdens on our MCOs in terms of, figuring out how and where they can go. And so I'm really excited and heartened to see this. And I'm excited to hear more about Senior One as you grow.
Awesome. Thank you guys so much. Thanks for the
Thank you so much. Great. Okay. Well, thank you so much, Othman and Evan. Again, this is just a small sliver of the really great innovative companies and services and technologies that are coming out of New Mexico. Certainly, we hope with our work through Health ImpACT to nurture more of that and bring more of that here to New Mexico. But we do have, some other health tech folks in the ecosystem doing the hard work like this. So thank you all for coming and demoing to us. All right. So with that, we gained a minute of time, which is awesome because I never put enough time in our transitions for in our tightly packed agenda. So let me share my screen. All right. So before we move on to the our last panel before a quick break, I just want to quickly call your attention to the QR codes on the screen. So for healthcare organizations and for health tech companies who are on the call today who are interested in learning more about Health ImpACT or joining the Health ImpACT Network, on the left, we have a QR code for healthcare organizations for you to be able to scan that. This is just a simple data collection form where you can provide some input on what types of challenges that you're trying to solve right now, what's highest priority for you, where do you think some new startup technology or novel innovative technology could help. And then on the right, startups and healthcare companies, health tech companies who are here in the audience today can fill out an application to apply to be considered for future pilot alignment opportunities as we start exploring, what kind of innovative solutions we can do some matchmaking for. I'll give folks just a minute to scan this if you want to scan it with your mobile phone, and we'll also be sharing this a couple of other times throughout the duration of the program. With that, I would like to queue up Erwin, Corey, and Greta for our next panel. So we have talked conceptually about all of these different innovation models, and we've talked a little bit, started to bridge into startups, and now Erwin, Corey, and Greta will move into the question that really matters. What does it take for a pilot to be successful inside a healthcare organization? But beyond that, how do we turn these into lasting, sustainable partnerships? So with that, I would like to introduce From Pilot to Partnership. It will be moderated by Erwin Cho, advisor at Shared Purpose Advisory and Chief Consumer Officer, former Prez, Kaiser, Blue Shield of California, and others. Erwin will be joined by Corey VanSpronsen, Vice President at Fabric Health, and Greta McAnany, CEO and co-founder of Blue Fever. Erwin, I will turn it over to you in your lovely panel. And you're muted.
Sorry. Hi, everyone. Always, there's got to be somebody who starts with not hitting the unmute button, and I guess that's me today. Great to see everyone, and what a great virtual conference already. Maybe through the reactions, we can give everybody a thumbs up for everybody who's already gone through. They've been absolutely terrific. So wanted to say thanks. My name is Erwin Cho. My experience sits at the intersection of healthcare strategy, consumer experience, and digital health. I've spent most of my career inside large integrated systems working to make healthcare simpler, more accessible, and more human, usually with more and more digital tools and now with AI. Today, I serve as an advisor to healthcare companies through Shared Purpose Advisory, helping organizations translate innovation into real world impact. But I'm very excited today to facilitate the conversation and to challenge us to think beyond pilots and buzzwords towards what it will really take to scale meaningful innovation across this healthcare ecosystem in New Mexico. I'm joined by Corey and Greta, and maybe I can ask Greta to introduce herself first and Corey right after, and then we'll get on to the questions. Greta, are you there?
Yep. Can you hear me now? It
Yes.
was saying I would try to unmute because I was not trying to follow in your footsteps, Erwin. And then it was like, host is not allowing people to unmute. And I was like, oh no, now I have the opposite problem, but we got it figured out. Hi, everybody. I am Greta McAnany. I am an entrepreneur and public health innovator, have been doing this work for the last 12, 15 years. I have a focus on youth mental health and technology, and, began my work actually in media, and then really saw that there was an opportunity to connect media, mental health, and young people together to create new kinds of healthcare solutions. And so Blue Fever is a front door care navigation solution for young people. We built one of the first evidence-based AI chatbots in 2017 for youth mental health on text message, and then have transitioned to an app and have really become we connect young people to care, but also open that front door so that they know that there is support there. And then more recently, I have also become the executive director of a policy advocacy nonprofit called MCERT, the mental health certification, which we are aiming to build a trust infrastructure for stakeholders in healthcare so that they can identify, fund, and scale subclinical tools in mental health and behavioral health that can help us as I think all of our caregivers are drowning trying to figure out solutions, and we are creating quality standards so that these tools can be better measured and show outcomes and efficacy. And I'll stop there.
Excellent. Thanks, Greta. My name is Corey VanSpronsen. I lead the go-to-market team for Fabric Health. I've been in the digital health space for about 15 years. Overwhelmingly, I spent my time with early stage startups, usually joining them pre-revenue. And then if all things go to plan, going through a successful exit. Most recently, I sold a company, Conversa Health, which I joined again pre-revenue to Amwell during the peak of the pandemic. Looking forward to the conversation today, sharing some of my battle scars and hopefully helping to inform how we can move quicker together from a technology and services standpoint to really driving better care and access.
Terrific. Before we get started for the folks who are in the audience today. If you're a healthcare system, let's start there. Add an emoji or raise your hand, do something just so that we can have an idea of who's in the room. All right. Well, how about for all the health tech startups? Some there as well. So it looks pretty balanced. Greta, oh, no, seems like a lot more healthcare startups than there are healthcare systems here. Today's topic's really about how do we take that first deal and prevent that first deal from stalling and really have it move forward, and how should healthcare organizations evaluate new innovations, digital health, health tech, and then for the startup and technology companies, what do you need to address for a health system or a payer, and what are some of the structural issues that can derail collaborations as we move forward? So I'm going to start with Corey. Corey, you work as a leader in sales and go-to-market for a fast-growing health tech company, Fabric Health, and you've done it for other organizations that have partnered with health systems. What are your biggest lessons or insights that you can offer early-stage health tech growth companies in partnering with healthcare systems?
Yeah, I think I can apply this to both sides of the coin, both for the technology startup, but also for the systems, the payers, the employers that are going to technology vendors, services, organizations to try to figure out what their next step is, what their next project is. I think the most important kind of central pillar is alignment of incentives. In order to do that, frequently it takes real work. It takes work to mutually design the structure of that pilot to determine what does success look like. If we are successful, what are those next steps? And then really holding each other on both sides accountable for the work that's required to make that pilot successful or to fail really fast. I think too frequently we toss around the idea of doing pilots like it is cheap or free or just something to try out a new solution. You're taking real resources as a startup and applying it to an organization. And especially in the early days when you're seed, when you're early Series A, spending time with someone who you aren't truly aligned with can be damaging on both sides. You don't want to poison the well for a health system who may really need those types of services, but if you don't have something that can really solve a core problem for them, you can really fall behind quite fast. So I think if there's one thing that I learned throughout my career, it is starting with alignment of incentives. And once you're there, working really hard and spending more time than you think that you need, developing the structure of that pilot, determining, do we need integration? What workflow is going to change? If we are successful, and in what time frame should we be successful? What are those next steps? And how do we actually turn this into something that will be a long-term, meaningful relationship?
Yeah.
Several of the points resonated for me, Corey, as you know, working for a health system, both in terms of the change management piece and thinking, we've heard that theme earlier today. Nothing is free. There's a lot of change management to do within a larger organization. And secondly, about incentives and making sure that the incentives are aligned. So, and the hardest thing to do is fail fast. So a lot of great points there, Corey. And Greta, I'm sorry I stepped over you on that. Go ahead.
Oh, you're fine. I was just going to add to that. I think Corey, you nailed it, right? And it's a simple phrase, but it's something very difficult to do. And like you said, it's like this is going to take longer than you think. And I want to actually dive into the how a little bit of Corey said, okay, well, you need to align incentives. And I think when you are like Corey said, my expertise also is in earlier stage startups, right? And especially startups that are coming and building products that maybe are a little outside of the comfort zone of health systems, especially with a focus, right, on subclinical tools. So when you're aligning those incentives, I want to talk about how, and I think something really tactical that I have done, and I always love to give tactical information since I saw we have a lot of startups here. So if you haven't done this yet, I recommend creating a stakeholder grid for yourself. So as you're going into these health systems and health partners, founders, understand, like, make sure you know who's your end user, who's your economic buyer, who's your decision maker, who's your saboteur. Like for one of the companies that I advise, it's in-house data science and engineering lead, because they're going to think that the product that this founder is selling in, right, should be under their purview, and we could do this ourselves, right? Understand who's going to be the influencer and recommender, and I think that if you can, and I can write those all out in the chat, but if you can get really clear that the decision maker, right, the chief officer, the influencer and recommender is going to be, your advocate is going to be the chief clinical officer or the VP clinical programs, really being thoughtful how you interact with all of those different stakeholders within that within that customer that you're trying to move towards. And I also think understanding for yourself, being very strategic and saying, like, this is like a foundation, who do I really want to work with? I think a lot of people is like, yeah, I just want to work with this health system and that, but do you want to work with their, IOP? Do you want to work with their EHR? Like, what part of it do you really want to work with? And so I just really recommend getting very granular so that you can do that really hard work that is that simple sentence that Corey said of, like, align incentives, because it's a lot of grunt work underneath.
Greta, you hit a really interesting point there of there's always health systems out there that everyone says, like, I really want to work with that health system. It's Kaiser, it's Cleveland Clinic, it's Mayo, it's whoever it is. It is, especially when you're in your first handful of proving out the solution or iterating on the solution, it's way less about a fancy logo out there and more on being able to find someone that you can really make a difference with. And if you can prove real meaningful change, real meaningful ROI, and you can do it in a relatively quick time frame, because we know that time is truly money in healthcare, and if we're not making an impact, we're slowing it down. You have to say no to more pilots than you say yes to, and you have to say yes to the ones that are actually going to make that impact.
It's terrific. And Greta, what really stood out for me in some of the comments you just made was really about identifying the champions and the stakeholders and figuring out who has an incentive to be a barrier in the work that you do, and how do you win them over. So terrific practical advice there. Greta, you've been a founder multiple times here, both for Blue Fever and now for MCERT, an organization that works with health systems and payers on trust infrastructure for digital mental health. Do the same lessons and insight resonate for you coming from the health system side, or is there something you would tweak to say it's different for health systems or payers?
Yeah, I think I have, recently I just held a convening in March that was focused on looking at these standards that we're developing, these quality standards that would apply to all subclinical tools, so that we could actually understand, what good looks like. And the payers that were in the room, some of the big names that we all know, what I heard them say that I think is really kind of applies to this conversation that we're having about piloting, is that they get approached all the time with, hey, you should pilot with us. Look at, this shows a bunch of efficacy. Look at our outcomes. And what I keep hearing from them loudly and very clearly is, that's great that you have outcomes, but show me your engagement plan. Show me that you not only uses your product, right, deal here or but should actually know how to roll the product, to use, download it, or engage with the clinician, whatever it might be. I need to see that as well, because a lot of them are feeling, oh no, I'm sorry. Can you hear me now?
You're good now.
Okay, sorry about that. I'm at a conference in a hotel, so I'm at the whim of the Marriott's Wi-Fi gods. Where did you, I was saying, and let me know if I'm repeating myself or not, but that you have to have a plan, not only to illustrate to payers that your product works, but that you have a companion engagement strategy that will create sustained impact over time, because you will not stand out to a payer if you just say, our product can do XYZ. You have to really prove that you know how to get continuous engagement and then really create that longitudinal benefit for them. And I think that's what's going to really make you stand out in this market, because healthcare's biggest challenge has always been engagement. And now I think there's a lot more creative ways that we can go and get that engagement.
So just fantastic, Greta. Thanks for those insights. We're short on time. These are all lightning fast and lots to talk about. Corey, maybe we start with you, and right after Greta. What is one practical insight that folks can take away from this session? Whether you're a health tech or health system, what's one assumption not to make, or one thing they should do to make sure that they're set up for success when they partner?
Yeah, absolutely. And then for the questions that we don't get to in the chat, I'm happy to type out some answers there. And Greta, I think you mentioned doing the same.
Yeah, happy to answer those offline.
Yeah, I think practically from the standpoint for a health tech company, getting comfortable with saying no to things. Too often pilots also turn into custom development exercises. I say no to a lot of pilots. And what has allowed me to circumnavigate that is I'm frequently structuring agreements, not pilots, that have easy outs after a year, but turn into multi-year agreements when we prove the ROI. If you can if you believe in your product and you have identified the right organization to pilot with, and you have aligned incentives, and you have proof or as much information as you possibly can that you're going to be able to tackle the right problems, putting your money where your mouth is and going at risk in that first year or first 3 months can help move things along. But you should absolutely make sure that you're saying no to all the ones that don't make sense, or you won't have the time, capacity, energy, or dollars to really apply and double down on the organizations that you can truly create something that's going to be long-term and meaningful with.
Awesome. How much time do we have left?
3 minutes.
3 minutes. Okay, I won't take up that whole time. I mean, I think that is such great practical, tangible advice, Corey. I'd say what I said earlier about stakeholders, really map that out. And then I think don't try to tackle too much. I think in these pilots, right, there can be scope creep, like Corey talked about, from the payer side of like, we want you to white glove do this and that, right? But also on your side, be very specific about what you offer. And I'd say don't try to boil the ocean. Just be like, we do this simple thing. And then from there, once you prove that you do that, like Corey said, then you can start to expand, right? I think a lot of early stage founders that I know are like, and then the product could do this and we're going to solve this. Just keep all those ideas in your product parking lot. And then once you've, I think, earned the right to expand with these partners, then you do that. But do not promise them the world. And this is very cliche advice, but under promise and over deliver, right? Just be very specific about what you're promising them, align on that, and then you can delight and surprise them when you say, oh, and then my tool also does this, and we could also help with this, clinician handoff piece, etc. That would be something that I just see founders too often get. Like, the vision is for pitching VCs. When you're pitching pilots, you gotta be very practical. And it's gonna feel, especially with like the founders, it's gonna feel maybe a little underwhelming to you. That's fine. But just deliver on something first.
Great. Thank you, Corey. Thank you, Greta, for some terrific insights that folks can take away here. Also want to thank all the HealthInno attendees for taking their time to listen to this panel, and thank the HealthInno organizers, Stefany, Angelica, and Joseph, Maxwell as well. All of you doing a great job to bring us all together here in New Mexico. And Stefany, if there's any interest in another conversation with myself, Greta, and Corey, we'd be happy to work with you to set something up for those who express interest. So thank you, everyone. And I'm turning it back with 58 seconds, Stefany.
Thank you for having us, and happy to chat more anytime.
Thank you so much.
Thank you. Yes. Thank you, Erwin, Corey, and Greta. What a great first half this has been. There are more questions in the chat, so we are capturing those and we'll send them to you all after the fact. As these conversations continue, we'll be carrying many of today's themes into the upcoming Health AI Summit on October 8th at Embassy Suites in Albuquerque. And that summit will go deeper on applied AI, implementation, workforce readiness, and what responsible healthcare innovation looks like for New Mexico. And now we're going to take a short 5-minute break.
All right, all right, all right. We are back. Thank you, everybody, for your comments and engagement. All right. So I'm Joseph Sapien, Program Director for HealthInno. Before we get started, we'd like to invite healthcare organizations and health tech companies interested in joining the Health ImpACT Network. Please scan the QR code on the screen. Healthcare organizations can share priority areas and operational needs, while startups can apply to be considered for future pilot alignment opportunities as healthcare organizations begin exploring innovation solutions. We'll now begin our second showcase segment. This is a glimpse into the kinds of advanced computing solutions we'll be surfacing through the Health ImpACT. First, we'll hear from Jonathan Grubb, CEO of Triangle Health. Jonathan, welcome.
Thank you. Great to be here. I'm going to share a screen here. Can everybody see that?
Yes.
Great. Well, thanks for having me. I'm Jonathan Grubb. I'm CEO of Triangle Health. We're building a health AI for patients with full medical history and context that's focused on education and activation for patients. So I'll actually just show you the product. First, I'll just say who we are. So we're really consumer product builders. We've been building different kinds of technology products I've been doing it for about 30 years. Our previous one, we took public on the New York Stock Exchange. So we make a lot of stuff that you use every day. And we're really focused on making consumer products available to wide groups of people. And we've teamed up with a team of doctors on this one. But I want to just focus on what it is that we're building. So this is Triangle. I'm going to jump over to a live demo. A little high wire act is always good for these things. So what we have here is a health chat. This is similar to ChatGPT. We're seeing that about 25% of people who use ChatGPT, which is like a lot of people, are using it for health questions. They are going and asking things every day that are it can be super helpful, but it's not grounded in their own health information and it's not connected in with the health system. So they're kind of going off on their own and doing research and then trying to bring it back to their doctor and finding that they don't add up. So what we've built here is a system that brings in first the patient's medical records. So we have a doctor who will gather all of their medical records, review them, make sure that they're accurate, and then place them into context for this health AI for the patient. And so that in this case, we just have some documents uploaded for a sample patient. For a real patient, this might be hundreds of documents. I just saw one today that came in with 396 documents, tens of thousands of pages of raw medical records. And what we're able to do is pull all of those together, run them through a system, and extract a set of health conditions. So here's a patient with this set of conditions. And then for each one, we're pulling a full medical history, the medications and treatments that they've done. We're making notes about it, showing the standard of care treatments and the emerging treatments, the new health options they might be considering. And so what we get is for the patient, they can ask a question like, should I try Ozempic? The question of the year for a lot of people. And this would generally get kind of a generic answer that has a lot of, well, if this, then that, and all these, a lot of general information, but what they're looking for is personal information. So what this is doing is going and reading all of their health history, reading all of the medications they've done, their entire history, and building an answer that's just for them. And then the idea here is not that they then go out and buy some Ozempic, obviously. This that they take it to their doctor. And we're looking to build something that really connects patients with their doctor and with an AI system that knows all about them. So that's what the triangle is that we're talking about. It's the doctor, the patient, and the AI. And that's different from some other companies and some other states that we've seen that are looking to replace doctors with AI. You can have a chatbot that replaces your doctor. We're not trying to do that. What we're trying to do is get the patient to be more educated and more activated and have a place that they can go to ask questions that they can then prepare and ask their doctor. So this is a pretty good answer to the question of should I try Ozempic? It's grounded in all of their conditions. It has the pluses and minuses, and then they could say, make a worksheet that I could take to my doctor and print out for my next visit. And we can put that together. We can put together the questions that they need to ask and the real kind of the full set of questions and answers that they need to gather to make this decision with their doctor. So some other things that we can do is we can connect them in with the doctors. We have a national network of telehealth doctors who can kind of vet the information that the patient finds here. There's always a question with AI of what about hallucination? What if it says something wrong? And we think that it's doing some pretty amazing stuff. A lot of AI systems are beating doctors at certain tasks, like different kinds of diagnosis and patient analysis, but we don't want to count on them alone yet. So we want to bring this to a doctor. So we have the ability to see a doctor. We can also order labs and testing. So a patient can say, put together a plan for what labs I should be getting. They can vet that with their doctor. They can directly order them, and then the results are placed directly in the system. So they can chat with them and they can have visibility into what's going on with their health. We can also do genetic testing. We're also connected in with family and friends. So this is a huge deal for patients, older patients, folks who want to get the most out of these systems but can't really do it themselves. We're seeing a lot of this where people want to be able to connect their family in. So we're seeing a lot of adult children who are remotely helping their parents, and they're able to give visibility into what happened in their doctor's visits and really do their own kind of digging and figuring out what should happen next and then bring that into their parents. We also have a low income program, so we're able to we're offering this to low income folks at no fee right now. We want to expand that and get into much larger systems, and so our ambition is really to get this available to everybody in New Mexico regardless of their income. And I want to leave some time for questions, so I'll jump to just what our asks are, what we're looking for. We've started a trial in California, in a rural hospital here, where every patient who checks into the hospital, or soon everyone who's sitting in the waiting room, will get set up with a Triangle Health account, and they'll be able to start doing research and start asking questions both about the hospital, what's available there, and about their own condition, and kind of making that plan and getting it together. And then when they leave the hospital, they have a plan that they can implement and that they can follow up on. So we're looking to expand that to New Mexico hospitals or other organizations that are in touch with patients. It can really be any touch point with a patient. We're also looking for grants and programs that can help support that. And then we're looking for investment. We're a startup, we're early stage, and we're really just bringing this to the world right now, and we're looking to expand dramatically in the coming years. That's really what we've done as startup founders, is build companies and products that go global in a pretty massive way. So you can try this right now. You can use it for yourself. You can use it for your family. See what you can find and see, put it through its paces and see what you think. And I'd love to take any questions.
Yeah, thank you,
It
Jonathan.
looks like we've got one from Jim here. Which hospital in California?
We're at Konya Health in Visalia, California. So that's it's a hospital that serves a lot of it's a largely Latino population. Majority don't speak English or Spanish is their first language. One of the cool things about these AI chats is that they work just as well in Spanish as they do in English, so we can engage people in any language. And it's a lot of low income folks and pretty poor health, a lot of farm workers and others who have not had great health care for their lives and are in a pretty tough situation. So that's what we're looking to engage.
All right, so you got Jim's asking to reach out there, Jonathan. So if there's no other questions, we'll move on. So thank you, Jonathan, for your time, and look forward to seeing you advance.
Thank you.
All right. Next up, we're going to hear from Dr. Amit Mehta, CEO and co-founder of Amplifier Health. Amit, I'll turn it over to you.
Great. Thank you so much. Good to meet everybody. I think I've met many of you before through our Builders Connection here, but today we're going to talk a little bit about Amplifier Health, which is one of our portfolio companies that I'm the CEO of. It has a sort of novel technology. Give you sort of just 60 seconds on sort of background of what we're seeing in terms of investment in the healthcare space and where this company fits into that. I think it's an interesting intersection with the sort of progress of where AI is coming for the constituents here. As investors in sort of health tech company, I think there is a bifurcation that's occurred in the road where AI is implementing in healthcare. And so we see a lot of infrastructure companies working on deploying AI for healthcare delivery. So better billing, pre-auth, patient care, B2B, B2C. And then there's a whole other area of what we call frontier foundation models or frontier work where the AI companies are not working on a SaaS or a per click or per patient kind of technology, but rather a foundational technology that is finding new drugs or is a frontier model to find something new in the human body or a new element or new opportunities in healthcare. So they're not per click kind of companies looking for B2B SaaS revenue. And the LLM companies from OpenAI and Anthropic is a good example of this, is that these are AI infrastructure tools that were built. For the first few years, these companies had LLMs on the market. There was no use case. People hadn't figured out where you would use ChatGPT or Claude until sort of the vibe coding companies came along. And then suddenly, a huge amount of adoption took off and now sort of generically has infiltrated the world. So Amplifier Health is a company that we've invested in that is a frontier foundation model. And what I mean by that is that what the company has built is a foundation model, much like ChatGPT, that infiltrates and uses AI as an infrastructure tool in healthcare for human inference. And what that means is that it uses the API or the tool is used anywhere where a human being is being evaluated for something, much like a vital sign. And what the technology is looking at the voice and understanding that in the voice, there's a host of biomarkers or signals that are signatures of what physiologically is occurring underlying in the body. And so conditions like Parkinson's or Alzheimer's or COVID or congestive heart failure, anemia, all have a specific signature from the human body in the voice. Much like if you do a CBC or a hemoglobin as an indicator for anemia, that is a biomarker or a signal for that particular condition. A whole host of conditions have a signal in the voice. Things that are almost incredulous, for example, pregnancy at 4 weeks all the way through, anemia. So what the company has built is a model that can listen to the human voice, take in hundreds of gigabytes of data every second, and then make an analysis for either the caregiver, a patient, a doctor, a institution, whatever that may be. So medicine traditionally has been deaf to voice. And what that means is that if you have an ambient scribe that hears, I am fine, that is very different than an 80-year-old who's suffering from congestive heart failure or a 20-year-old who had a lot to drink last night. They're both fine, but they're both heading in very different directions. So typically we've used vital signs, heart rate, blood pressure, temperature, to be an understanding of where that human being is headed. But when you introduce LLMs into the equation and you're seeing AI use LLMs to evaluate, a patient says, I am fine, or I have a headache, there's no understanding of what is actually going on in the human. When a human says, I have a headache to ChatGPT, it says, you may either have a headache, a migraine, a glioblastoma, a stroke. There are lots of possibilities. A model like this, where it listens to what the human is actually saying and looking for these biomarkers, would understand that that human is actually having a stroke and this is an emergent condition that they need to go to an ER. So this model is able to hear what an LLM isn't, which is going beyond the words and understanding physiologically what is occurring in the actual human being. This has been trained on millions and millions of minutes of both normal human speech as well as ICD-10 labeled physician-patient interactions across these conditions. So the base model is built on understanding what signals are in the human voice, and then the model is fine-tuned on these conditions. So for example, the model is very good at detecting things like Alzheimer's and Parkinson's disease. We've taken hundreds of thousands of patients with these conditions, train their model with their voices, specifically looking for the signature of the genome, acoustic genome, and then the AI can understand that a new patient that's introduced to the model from a classifier standpoint can diagnose. So what we're able to do is take the audio in, and that comes from anywhere, whether it's a phone, an ambient scribe, a patient calling a call center, if you're an insurance company, a hospital outbound calling post-op or post-procedure, anywhere we get audio, no news source, we can take that, run it through our algorithm called SONA2, and come up with a multidimensional biomarker vector of understanding what is going on with that patient. And I'll give you just an interesting pilot we're working on with the Cleveland Clinic. They have a significant interest in post-op care. So when you have surgery, we typically in the PACU or the post-surgical recovery, people get sent home because they feel well, they're passing gas, they're eating. There is very few metrics that determine whether or not someone gets sent home. And so there's a length of stay issue there. So from the voice, we can detect things like hypotension or sepsis, or things that would cause failure if the patient has been sent home. So we're working on a project with Cleveland Clinic where we do this ambient listening in the PACU and determine and surface these kinds of things for the providers in determining when a patient can go home. So just a bunch of use cases here, and I'll wrap up. And I'll let you read these on your own, but anywhere from telehealth triage to clinical trials to payer risk stratification, anywhere where a human is being evaluated, there is some element of both voice and a need for analysis. So you can catch a patient with CHF before they decline and end up in an ER if you're on a VBC. You can find and triage patients for clinical trials if you're doing a Parkinson's drug, or you can look at patients in between dialysis sessions if they're getting anemia. So many, many uses across the healthcare system where voice is that primary modality for identifying these patients that may be running into issues. Hopefully that leaves a couple of seconds here for questions.
Yeah, we have about 2 to 3 minutes left. So any questions for Amit?
Everyone's dumbfounded. That's the perfect response.
That's an amazing technology. Amit, I do have a question. What would an ideal kind of pilot look like? It looks like this is something that could probably come in fairly quickly, easily, and start to work or show value soon. Could you speak to that a bit?
Yeah, I think one of the things that we've focused on from a pilot standpoint, as someone who's been on both sides of this equation, on the healthcare side, giving pilots, and then on this side, looking for pilots, is that this is a frictionless technology that the biggest thing is integrating into existing workflows. So whether it's a call center or ambient scribe, is stepping in and doing pilots that are accretive to the organization for some intended ROI, whether it's length of stay, whether it's finding more patients to bill a code, whether it's to look for failures in a value-based system before they end up in an ER. So all of our pilots and what we look for in pilots is where can we make an impact to the bottom line of the healthcare institution for either the institution, the patient, or the provider. And that is trying to do that in a very frictionless sort of setting. And that has resonated with most institutions that we've worked with. The sort of prevalence of ambient scribes today has been sort of a boon for this. But I think everyone agrees in the AI world that there is a movement and a convergence to voice, in that everyone is trying to interact with these tools in a frictionless manner, whether it's on a phone or an ambient listening device. And so it's taking that repository of voice data that a lot of institutions have already. For example, when we were talking to UHC, they record all their call centers calls. Like, they have a repository of data already that they're not doing anything with, that lets them monetize and move into using the data for better patient care.
Awesome. Thank you so much. Okay, well, I'm sure we will have lots of questions. Thank you so much, Amit, for joining us. With that, we are going to transition. I shall.
You're muted, Stefany.
Oh, I'm over here just chatting away. Awesome. Thank you so much, Amit. That's great. I always love to hear about Amplifier. I think it's so cool. I'm sure we'll have lots of questions and comments coming in. But with that, we're going to transition to our next session. So I've popped a link into the chat. We would encourage all attendees who are on the call, but especially anyone who's working in healthcare, a healthcare leader, a healthcare clinician, someone who's worked in or around healthcare, their careers, and of course, health tech companies, health solution companies, to join, to participate in our next 20-minute interactive session on your web or your mobile. So here's some instructions on the screen as well about how you can join. We'll be using a tool called Mentimeter, so you can have it on your phone, and I'll be sharing some results on the screen, or you can join in another window on your computer. I will give folks just a minute to join that while I pop over to the Mentimeter. Okay, let me stop this guy and share my other window. So let's log it in because it does take some minutes sometimes to log in. Okay. And you should see as you're logging in, you'll see how many people are kind of on the how many people are logged in. So we got 33, we got some likes, I got some hearts already. I haven't even said anything. Thank you. All right, so I'll give folks a minute to log in. So another way, so you can click on the link in the chat. If you can't do that on your Zoom and all that, you can scan the QR code that's on the screen right now with your mobile phone. That'll take you to the Menti as well. Or if you can't get access to any of that, you can simply go to menti.com and you can enter in code 41045700. Now, what this session is, it's going to be a fairly quick interactive session where we're going to use this Menti tool to solicit input and feedback and thoughts and ideas from everybody here on the call. All of your answers will be anonymous. We can see who answered what as organizers, but we will not be sharing out or using this in any way for any kind of commercialization or sales or outreach or anything like that. What we're trying to do is simply to capture what's top of mind for everybody as we've talked today a lot about innovation and things like that. So with that, let's get to it. First, tell us a little bit about yourself, just your full name so we know who you are, and tell us what state you're hailing from. You can just do the two-letter abbreviation is fine. Give folks time. I can see how many have answered. And I like to kind of start with some easy ones just to get folks familiar and comfortable with submitting their answers. Is anyone having problems or challenges? Pop it in the chat with the Menti and we'll see if we can help to troubleshoot. Again, I would love to hear from anyone, especially folks who are in healthcare and have worked in or around healthcare, and especially from health tech companies here on the call. All right. So tell us what kind of organization you are. What kind of organization do we have in the room today? Healthcare orgs, health tech companies, startups, funders, public sector leaders, researchers. Oh, this is awesome. Okay. Service providers, I define that as like solution or service providers, maybe not so much health technology. Give folks a few minutes to sign in here to get this going. And if at any point you get kicked out or forget how to get back in or you join us late, again, you can join at menti.com using this code here at the top to join us and give your feedback. All right, we got some stragglers. I see 41 folks on and about 25 answers. Can we get some more? Is anyone having technical issues? Also, too, if you feel that a question doesn't necessarily apply, you don't have to answer it. You can just wait it out and skip it out, which we'll have some folks doing with some of our questions. All right, this is great. So as suspected, we have about a third healthcare organization and about a third health tech startups and about a third everyone else who's interested in helping health innovation take hold in the state. Oh, great. I would love to see all of our public sector leaders in the room. Thank you guys for joining us. I like to remind everyone, policy is more than just like blah, blah, blah policy. It's like how things are reimbursed. It's how funding moves. It's how we, orchestrate things across the state and what we make happen. So you all are the man or woman, as it were. All right, so that's good. Let's move on to the next. So I thought this would be fun. Drop a pin for where we have folks joining us from here. I know we have some folks who are not just from New Mexico, and I want to see what our representation looks like. Oh, we got somebody. Is that Oklahoma or is that the tip of Texas? I can't tell. Oh, we got some regional counties. Love to see it. Thanks, Eric. We love to have you always. You're one of our biggest champions. We got a lot of concentrated here around our metro area. Oh, we got some folks down south. Good to see it. California representation. I'm not going to call out some of these because I'll reveal that healthcare is my expertise and not geography. So Midwest somewhere. And just laughing because this has bit me in the butt. Thanks to my one commiserator who liked that. All right, this is awesome. We got a good spread. So one of the reasons we did, I know many folks were kind of disappointed in the virtual format, which turns out still is quite a lot of effort. But one of the reasons that we wanted to do virtual and will continue to do more virtual events is because not only does it allow us to have great speakers from across the nation, as you all have seen, but most importantly to us, it does allow us to sort of reach outside of the metro area and engage folks, especially folks from our rural communities or our communities who are not always at the epicenter or can't make it up to Albuquerque or Santa Fe for events. And so you probably can't expect to see more virtual events from us here in the future. Thank you for that. All right, so now that we're kind of comfortable with the tool, I want to hear from everyone in the room who's logged in here. What are the top 3, up to 3 communities or populations or health conditions or issue or whatever it may be that you are most focused on this year? What is top of mind, important to you? What are you building? What are you working on? What are you trying to solve for? Healthcare organizations, what are you most concerned about? Who are you most trying to better serve this year? Up to 3. Oh, thank you. Spanish speakers, Native American, thank you. Underserved rural, we got some behavioral health. Oh, more behavioral health, a lot of rural. Some other variations of rural. I see Medicaid in here. Oh, efficiency, that's a good one. Children's health, thank you. We don't talk about that enough, I think. Oh, look at rural's affordability. Moms in need, children's, Latinos, primary care. What else we got out there? Underserved, yep, that's important. Oh, sepsis prediction, that's very specific. Indigenous communities. You'd think that these word clouds might be a little bit smarter with all the LLMs and could probably group these for us. We'd probably see some better themes, but not to fret. We will do that on our side and send out a summary with things grouped up a little bit better so we can see this. But this is great. So, already popping out, we're seeing Native American and Indigenous communities, behavioral health, rural, underserved, and Medicaid communities. Seeing a lot of mother-baby children in different ways, shapes, and forms. So that's really interesting. All right. Thank you, everybody. Okay, so the next set of questions is just for our healthcare organizations who are in the room. That could be payers, health systems, providers, clinics, academic health center, researchers, state or county health agencies. So everyone else can just kind of sit this out. But for healthcare organizations, what stage are you at in your innovation journey right now? You're curious, but you haven't started yet. You've run a few ad hoc pilots. Dedicated innovation function, great. I'm assuming that folks who aren't answering probably are like, well, maybe we haven't started that at all or started to talk about it. Piloting with some regularity and some process, that's great. My suspicion, my hypothesis here was that we'd have kind of a little bit early, like ad hoc, some conversations and some regular piloting. I am thrilled to see how many folks have a dedicated innovation team or function. That is awesome. Awesome. Okay, now we're getting comfortable here. I'm going to pick up the pace a little bit. So a moment to brag, healthcare organizations. What is an innovative program or tech initiative that you're working on right now that you're proud of? Send us one. Could be anything. It doesn't have to be tech. It could be like, I know UHC is doing a lot around doulas. I know we've got a lot of cool collaborations going. In the interest of time, I'll move on since folks have to probably think through their roster of all the different initiatives that you're being tasked with doing right now. So not to fret. All right, now this is the kind of meat and potatoes. So what I would love to hear from everybody, healthcare organizations in the room here today, what are the biggest challenges specifically where you are focused this year that you think technology could possibly help to solve? It's okay if you don't know if tech's the answer. It's okay if you don't know if anything even exists out there, but think of places with high urgency where the answer might be clear. What are some like administrative burden? We got some great comments in advance about using AI to advance clinical care as opposed, for primary care as opposed to advancing revenue cycle, say. So what are some specific areas that that you think that technology could help to solve? I'll give folks a minute to type in their answer. Coordination of care. We hear that come up a lot. So yeah, no shows. Cost increases, both internally, operationally, if you're a health system, as well as if you're a payer, your population, your MLR, all that good stuff. Collaboration among healthcare providers, agencies, and innovations. We would love to see that too. I'm glad you're here, whoever said that. Specifically help Native Americans and underserved. Automation, digital experience. Great. Okay, cool. As you think of more, I'm going to try to figure out how to open up this survey after the fact, and you can always come back here and add this, but I have a few more that I want to get through. Documentation timelines to enhance revenue cycle. Okay, that's a good one. Making that speedier and faster to get a clean claim, and making sure that you're capturing all the hard work that your docs are doing. Quick turnaround. Whoever typed that one, I'd love to hear a little bit more about what kind of quick turnaround. Maybe payment. All right. I'm not going to do a voting. I'm just going to skip here. Okay, so earlier today, I talked a little bit about that spectrum of innovation readiness, or the spectrum of the different types of innovation models, from piloting to co-developing to even incubating early stage ideas to full-on venture investments. I'd love to hear, as a healthcare organization, where are you at on this spectrum? If you're not currently with a healthcare organization, I know many of you have been previously with one, and you can speak to this. So please do feel free to kind of bring your knowledge and expertise on what's happening in healthcare in New Mexico around this. You can select more than one, which is why these numbers may add up to more than 100%. Some folks have told us that they're interested in all of these different types of models. This is really, there's no right or wrong answer. It's just for us to kind of gauge kind of where everyone's at in the ecosystem, how people are thinking about innovation, and where are they plugging in, of course, especially as we're building out even partnerships with our academic health center and our researchers in the community. There could be lots of opportunities for co-developing bespoke solutions and doing things like venture studios where you're developing very nascent early stage ideas. There's lots of opportunity here. This is awesome. Seeing some good appetite for that. All right, now with that, I have our next set of questions for what I've called just generally solution and service providers. So this could be startups, early stage companies, growth stage companies, consultants, vendors, advisors, tech solutions, founders, stuff like that. I know we have a fair amount of you all in the room. So I would love to hear from you all. This is your opportunity. Share your company name and tell us what your company does. And again, we will keep these answers anonymous. However, I suspect that the startups may not mind if we share the results of this. So let us know. What do we got out there? What problems are you all solving for? And I know this is up to 200 characters, so folks are fervently typing away. I should have told you to have your vision statement already. Abdu, pop in there what you guys are thinking about working on. That would be a good one. I know we got lots of innovators in the room here. I'm always hearing of a new idea, something new coming up. Prosperous Research Systems. Haven't heard of this one. Developing a no-contact brain-computer interface using RF ultrasonic sensing. Interesting. Access for rural communities. Lovely. We always love to hear that. Of course, we always go to the, what does that look like and how? Is that extending care across distance through virtual medicine? Is that digital remote patient monitoring tools? Partner bioresearch with the community-based platform. Let's see, is Nipa still here? I know Nipa's doing a lot in maternal health. Oh, there she is. Ending maternal mortality. Nipa, you need to talk to Abdu. He's interested in that. Pediatric health, uber.made. Excellent. Maternal health, architectural medicine. This is such a great one, Tim. A software platform to measure issues in buildings relative to health and healthcare. Someone focused here on tribal communities, Alice Springs Consulting, Tribal Liaison, New Mexico Startup Alliance, right resources for entrepreneurs at the right time. Great. I'll give folks just another couple more minutes. We'll have just a couple more questions. Good stuff. All right. Now I'll also ask the same group of solution and service providers. What is the one thing that you wish healthcare organizations knew about working with startups or growing businesses like yours? Again, this is another long form, open-ended question, so I'll give folks a minute to type in their existential thoughts here. I think this is always important, especially as a former entrepreneur. Go ahead, Ange.
Well, I was going to say this could be an essay for many. So,
well, why don't you tell us,
hard
Ange?
to distill.
You're the entrepreneur who forced me to leave my job with no clients in the pipeline. Tell me, what do you wish healthcare orgs knew?
We're in it for the long haul. And so there are a lot of tourists in our space. And so I think for folks like us and many on the call who have spent their careers in the space in healthcare and to innovate, I think learning to weed out those folks versus those who have popped up overnight.
Thanks, Sandy. I wish they knew how to engage with innovation that are built through a different pathway. And, the benefit of additional data sets to inform health along with public health. I love that one. As you all know, I love data and complex integrations. Also believe deeply in the power of that. Accessibility and willingness to engage with innovators. Thank you all, 4 brave souls for sharing that. All right, the last 2 questions for everybody in the room, regardless of where you sit. Where do we go from here? Number 1, what would it take for innovation efforts like everything we're talking about today to actually take root and sustain in New Mexico? What do we need to be thinking about? Just don't agonize over it. There's no right or wrong answer. What is it? Is it funding? Is it partnerships? Is it tighter collaboration? Is it more entrepreneurship? What is it? I don't know. You guys tell me. I should have made this a word cloud because it forces the shorter answer. Oh, Angie says regulations in the chat. Thank you, Angie. Oh, that's a good point. Yeah, if you want to just pop stuff in the chat, feel free to do that too. Financial incentives that align with the positive change. One of the things that we've heard a lot about the ecosystem building sector, I guess if you could even call it a sector, I don't know if it is. A lot of times it's invisible work where like people are toiling away to do in events and community building and all the stuff that doesn't really have it doesn't really pay. There's not a lot of funding streams for it. And then to get to those, strong innovation ecosystems like the ones that Stefan talked about earlier, when we see things further along on that spectrum, we're actually seeing, more state investment and infrastructure investment and city, state, and local investment in things like that. And so I think this is great because I really do feel, and we'll hear in the next hour from some leaders across the state who are driving a lot of this collaborative innovation and a lot of this collaborative funding models and stuff like that about what they're doing. Public-private synergy, I love that. Support before traction and R&D support. Yep. I would love to see more. And one things we'll be working on with UNMHSC is figuring out how we can see more health tech come out of our tech transfer programs, things like that. Clear KPIs, testing environments, biotech in addition to quantum, policymakers involved. I'm seeing a lot of policy and partnerships and funding collaborations. But I like this about the clear KPI. What is it we're trying to do? And finally, simple word cloud, 1 word, 2 words. What are you walking away from today ready to learn more about, explore, or find a partner for? It could be something like voice biomarker AI. It could be, oh, you're leaving encouraged. Thank you. Okay, sure. How are you feeling? Knowledge and hope. Oh, lovely. Inspired. I know sometimes we get up here and we're talking about all the great things and all the innovation stuff. Please make no mistake. We know this is a hard road. We've been working in healthcare for many, many, many years with many of you here in the room. I do feel like we're on a precipice of change. I've seen more momentum and excitement and appetite in healthcare than ever before, which is great. As you know, healthcare is our largest industry, economically speaking, by job numbers. And then we're second only to oil and gas by revenue numbers. And so it's just, we're awesome to be able to, we're honored honestly to just be able to be part of all this work. Awesome. All right. Thank you, everybody. That is the end of our session. My time is up. All right. With that, Ange, you're up.
All right. Well, thank you to everyone for contributing to the discussion. We just want to call attention to our QR codes again. So we'll bring that up here in a sec. For people who just joined us, want to call attention to these QR codes, which we'll be displaying here shortly.
I'm having a little Fritz inch, so why don't we just go ahead and introduce
Okay. All right. We've showed him a lot. Okay.
Yeah.
All right. We'll now move on into our next session, the bigger picture, healthcare and innovation momentum taking shape across New Mexico. We'll hear 4 brief presentations from state, research, data science, and rural health leaders advancing health innovation efforts across New Mexico. It is our honor to first welcome Nora Meyers Sackett, Director of the New Mexico Technology and Innovation Office. Nora and her team are helping shape how New Mexico invests in entrepreneurship and innovation infrastructure across the state, including the investment and support for Health ImpACT. Nora, thank you for your leadership and for helping make this work possible. I'll turn it over to you.
Thanks, HealthInno team. Really glad to be here. Hi, folks. As Angelica said, my name is Nora Sackett. I'm the director of the New Mexico Technology and Innovation Office. I'm going to go ahead and share my screen. Give me 1 second. Sorry. You'd think by now I'd be faster at this. I apologize.
Entertaining for us all day. No worries. I have like 8 different windows open over here, so you're in good company.
There we go. All right. So as I mentioned, the New Mexico Technology and Innovation Office is a division of Economic Development New Mexico. And our mission here at ED&M is increasing economic opportunities and providing a place for businesses to thrive. You may have been familiar with our administrative predecessor, OSST, the Office of Strategy, Science, and Technology. OSST became TO, the Tech and Innovation Office, with new legislation passed in 2025. So really exciting moment over here. I think there's been some discussion of this momentum that we feel in tech and innovation here in New Mexico. And we've seen that at the state government level as well. When I started in this role, at the time it was the Office of Science and Tech. 3 years ago, it was an office of one, and a very small budget carved aside from another division's budget as kind of a, here you go, we'll give you something to play with. And now we are an office of 9. We are our own division with statutory authority. We have a new board, advisory board coming online. We have a new fund and dedicated funding that is considerable. So really exciting moment for momentum for tech and innovation here in New Mexico. There we go. So as I mentioned, the Tech and Innovation Office, what does that mean? What are we doing? So our mission is to support the connection of New Mexico's innovation infrastructure to the commercial market. We work to encourage and enable startups, the growth of tech and innovation companies, and the establishment of tech and innovation companies in New Mexico. And we look to grow and diversify those existing tech companies and identify opportunities for innovation commercialization that aligns with New Mexico's unique strengths and market demands. How do we do that? We do that through a variety of ways. One is non-dilutive grants, specifically for startups, for businesses commercializing technology. I think one that we see bio represented a lot in is our Science and Tech Business Startup Grant. This year, about 1/3 of the awardees were bioscience companies. We also offer grants for ecosystem support, how I'm here in this meeting today. I'll get a little bit more into that in a minute. We do resource connection, business navigation for folks exploring other state incentives to grow their businesses here in New Mexico. So, we're talking about how these sectors grow in New Mexico. And one of the things that we did last year was commission a science and tech roadmap. So we really sought to answer the question of in what fields is New Mexico strongest and has the most unique strengths and opportunities in tech and innovation, and what levers do we need to pull to advance our strengths and our position in those fields. We got to work with a firm called Techonomy Partners. They used to be the in-house economic development arm of Battelle. If folks are familiar with Battelle, and that was something that was really interesting to us because the national labs are such an integral piece of our innovation ecosystem here, but they also have unique difficulties, right? Unique circumstances of that. And so having spun out of Battelle, Techonomy sort of really understands what those attributes, those strengths mean, but what the challenges are of having labs in someone's ecosystem. So we really enjoyed working with them. We published this at the end of last year, I think. And the full thing is on our website. It's quite long, but it's really excellent. And I really encourage folks to take a look at it if you haven't already, and if you're interested. And what it identified were 3 existing growth opportunity areas that are listed here, and 2 emerging growth opportunity areas, one of which is bioscience innovation. So, bioscience has been one of our target science and tech sectors here at ED&M previously. I think what this roadmap really helped us stratify or clarify is there are sectors perhaps that have, as it says, existing growth opportunity areas. There's clear sort of momentum. And there are ones that we have really great base strengths in, particularly in research, and that there's a bit of a gap in sort of the clarity in industry catalyzation and growth there, but that there's incredible opportunity. And so that's what they found biosciences innovation to be. I've gotten some pushback, frankly, on the way that these are categorized, which is fair, of folks saying that it sort of, undersells the strength of the existing industry here. And I think those conversations are really important. I also think it's really important to acknowledge what our gaps are in advancing this ecosystem. It's one of the reasons I'm so excited about HealthInno and what this team is doing, because I think it's really trying to address one of those gaps. So getting into that, this is more from, sorry, I should have come to this slide. This is more from that report on those existing growth opportunity areas and the emerging opportunity areas. You'll see some of the areas broken down here for biosciences that were identified as particular unique strengths for New Mexico. So we mentioned one of the ways we do this is through grant funding. And one of our new grants, this is the first time we've done this, we got more funding. And so we were able to expand the kinds of support we're offering. It's our Entrepreneurship Programmatic Support Grant. Really not a sexy name, but intended to support the programs that are supporting entrepreneurs in our tech and innovation sectors. So this is grant funding for programs and services that advance innovation, entrepreneurship, and tech commercialization in our target sectors. And we were super excited. It was a very competitive field. We got a lot of applications, and very grateful to everybody who submitted an application for that. They were really all fantastic proposals. And we were very excited to make an award to HealthInno for their program. Some things that really stood out to us for HealthInno's proposal were the university industry partnership, something that is really clear for us at TO is that we can't do any of this needed advancement in silos. It can't be just universities, it can't be just state government, and it can't be just industry. There has to be partnership and collaboration and shared responsibility and shared understanding. And so the partnership in this program was really important to us. Also really important was the pilot element. We think it's a really key element to providing New Mexico startups a platform to meet industry. That's something that we have really had a lot of feedback from startups and entrepreneurs, something that has been harder for folks to do in this ecosystem is really get some industry. And this is not just in bioscience, this is really across all those sectors. industry really to open a door for really new startups. Something that we see in other ecosystems who maybe have, particularly bio, I would say, who have a large industry anchor in that ecosystem. And so having this program really focus on pilots to support that was really important for us. And also, obviously, sort of broadly our focus pathway to commercialization, and ensuring that there is that pathway and identifying the steps needed for businesses to grow and commercialize, and enter the market while they're based in New Mexico. This thing on the top is pulled out of our roadmap. And one of the particular things recommended in the roadmap, in order to, as it says, create an innovation ecosystem that enables the translation of research into the commercial marketplace, was to invest in entrepreneurial support. You'll see that in that middle right bubble. And so this is just to exemplify, really, we have some things identified in this roadmap as gaps that we need to deploy funding into to support entrepreneurs and the organizations looking to support entrepreneurs, and really excited that we were able to do that with this funding. That might be my last one. Yes, great. Okay, so I know we wanted to leave a little time for questions. There's a lot going on here at TO, but we're really excited about this award, and I'm so excited to see how many people are on this call. This is really awesome. I think I just want to give the HealthInno team some kudos. They're really exemplifying what it means to bring industry to the table and generate excitement about this. And you guys are doing an amazing job. So appreciate everybody leaning in that's on this call as well. And I'm happy to take some questions if we have time.
All right, we do. And we've got a question from Tim Rossi. Will this new grant process help to match mentors for startups? I've struggled with finding mentors to help guide through the startup process, especially around funding and grants.
Yeah, that's a great question. So we do have a program that we have been piloting for the past year-ish, our business assistance program, where our office has contracted with organizations in the ecosystem to lend some of that specific support. And so we have a contract with the Bioscience Center for Bioscience to provide direct entrepreneur support. Would love to hear some feedback from, I'm so sorry, I'm forgetting the name of who asked that, if they have interacted with that program, or if they haven't yet, happy to make an introduction. We are also, looking at how we tweak that program to best address the needs of entrepreneurs. I think it's really, from the state side, we're trying to make sure that we are in our lane, which is we are not all of us here are business experts, right? And that's not really our role too. We are state administrators. Timothy, I see your comment. Okay, awesome. Yeah, it's on our website, edd/TO, and our business assistance program. And there's a link to get started there. We can follow up with you there.
Thank you so much, Nora. And Ange, I want to add one thing. I said it in the chat, but just for folks who aren't following that, we were absolutely delighted this year to see on the roadmap population health, what I'd call population health sciences, but population health data and analytics tools, especially big complex data sets and advanced sim and modeling, stuff like that, for the first time pop up. And while you said it popped under bio, which while you said the groupings, sometimes have discussion, one thing I realized we didn't elucidate here on the call earlier is sort of where we as HealthInno fit into that whole, like, sometimes people are like, is it bio, is it not? We identify a lot more as health sciences. We draw the line between is it bio or not if there's an FDA approval involved or a clinical trial. It's not perfect, but it's kind of the easiest delineation for us. And so HealthInno, if anyone on this call is wondering how or if we intersect with bio or med tech or all the other kind of ancillary overlapping areas, population health tools and analytics, and of course, big data and AI and all that stuff, we're absolutely interested in. Advanced computing technologies, as the name implies. But that's, I just wanted to clarify for folks, because your slide got me thinking that we might want it to be a little bit clearer there on sort of where we want to stay in our lanes, because there's, as you said, a lot of great organizations already doing a ton of great work in that whole bio area. So thank you.
Awesome. Yes. Thank you, Nora. All right, next we'll hear from Dr. Raj Vadigepalli, Senior Associate Dean of Research and Research Education, Director of Medical AI Education, and Professor of Internal Medicine at the UNM School of Medicine. So very unaccomplished. Raj will share a research and innovation perspective from UNM School of Medicine. Welcome, Raj.
Thank you. Can you hear me okay?
Yes.
Fantastic. Oh, this has been a very exciting day. I've been looking forward to it for a while now. So I'm glad to see the robust participation of, several people here, and amazing. We're off to a great start. Congratulations, HealthInno partners here. All right. You see my screen yet?
Yes.
Okay, fantastical. So basically, I thought I could give an overview of the kind of innovation strategy or vision of the School of Medicine rather than go into specific programs here. And people have been talking about, for a few minutes now, staying in lane. University is where all lanes intersect. We're all about mixing up the lanes. Right. So rather than us staying in the line, we are the place where everybody can forget about lanes and come together and do work. That's how we see our place in the society, if you will, in some way, right? In terms of openness. So I just want to give a bit of an intro to, if you weren't aware about the School of Medicine and what we do and where we are and so on. We're actually the only MD granting medical school in New Mexico. So it's a very interesting position, right? And that is critical to driving health innovation in many ways in our beloved state here. And there are learners across many programs. I mean, you might think of School of Medicine as, okay, we train MDs, but we do a lot more than that. We actually have PhD programs that are run here, MD PhDs and health professions in a variety of healthcare related professions, right? And all of this training occurs in the School of Medicine at UNM. And so this is crucial for people to understand, because when we think about innovation in health, the training part of the healthcare workforce is happening here in all different ways. And so keep that in mind as you think about innovation in health beyond just medicine as a doctoral program in some way. And we are nationally known for our innovations in primary care and how we provide care for a long time now. Many primary care innovations actually came out of New Mexico here, and with the focus on rural health and so on. And we pretty much, that UNM, train majority of our physicians and also, ergo, given our position in the state, majority of the healthcare workforce as well. And so that means that any innovation training that we can bring in here has a big potential for huge impact in how healthcare is practiced and executed in our state here. So something to really take advantage of, to maximize the potential of where we are in some way. And as we think about that, our mission is really, it's not just about educating, it's about how we bring together education and research and care into an integrated whole, if you will, to drive how people, both in New Mexico and beyond, benefit from the discovery and benefit from training and benefit from innovation and care practices everywhere here. So that is a vision that drives all our missions across healthcare, education, and discovery and research and translation in some way, right? And so speaking of research, the huge emphasis is on how are we going to translate our research all the way into the community, and not just as something we do to the communities, but rather engage them from the get-go, right? I mean, that is a big emphasis in how research is carried out at the School of Medicine at UNM. And there are many centers, and these centers are not meant to be silos, but these are where concentrated activity happens on specific topics, including our comprehensive cancer center, which is very long-standing, and our clinical translational sciences center with University of Arizona, which is also a long-standing center that is highly collaborative, and Center for Global Health. I mean, I've noted a few here, and these are all really topics that are extremely relevant to the health needs of the state of people and people of New Mexico and our partners everywhere in the global community, right? And so how are we actually going to now, as the technology is advancing, as AI was mentioned, right, a few times already today, I'm sure, and devices and miniaturization, computing, when data deluge, when you consider all of this, how do we actually take all that and inject it into our existing focus in conducting discovery and translation to meet the needs of the people here? How do we do that? That is the next phase of evolution of where we are trying to go. And so as you think about that translation, I'm just putting up a couple that I thought might be particularly interesting to this audience. There is clearly a lot more to do beyond what I'm highlighting here. And one of it is related to how do we actually bring in innovation and bring in AI and health tech training into our workforce expansion, which is of a big priority and need for the state, right? So how do we bring in innovation in terms of how fast we train people, how well we train people in taking advantage of this technology innovations that are emerging at a pace that is unprecedented, right? And Dr. Amos will speak a little bit more further into some of the emerging programs, including graduate level programs in health informatics and AI, possibly. But all the thousands of learners I pointed to you in a couple slides ago, they're all actually not just getting trained and getting educated, they're doing that as part of through a research-based training. So every one of our medical students are required to do research, and obviously our PhD students and masters and other students are conducting research. So as we are doing a discovery-based, research-based training to our workforce, the innovation-based comes naturally in our system, right? Now it's all about how do we partner, who do we partner with to enhance that and make it relevant to the current needs, relevant to the current industry, relevant to the emerging challenges, taking them on when it comes to digital twins, personalized medicine, and startup world, business training, and so on, right? I mean, I hope we can have all those conversations and stimulate that work through the HealthInno partnership here and with other partners as well that I mentioned on this here. And I just want to give you a bit of a perspective here. This slide comes thanks to our rainforest innovations from UNM, and all the circles ones are the ones that are connected to the UNM School of Medicine, are started by one of our faculty or somehow related to the research that's been discovered and driven from the School of Medicine, right? And this is just a sampling. There is many more than this. There's just a recent sampling that I want to pull up and say, as we think about, as you see, a lot of these are, this is not about the devices or AI revolution. That is the next phase that we see, that what are those partnerships that are going to come up through the HealthInno and others on the call here, and who others that are looking to join this journey here to get on this board here, right, in some sense. And so we are very excited from a School of Medicine point of view. We are all in terms of transforming our healthcare practice, education and research-based training, rigorous training in the most current innovative methods, and using that not just discovery, but also all the way to the community engaged translation through and through. So with that in mind, I would like us all, welcome you all, come join us, let us innovate together. And I leave my contact info if you would like to reach me as well. I'm happy to take any questions.
Thank you, Dr. Vadigepalli. I have actually a couple of questions. So we hear a lot about what you said, tech transfer, faculty researcher inventions, the kind of the traditional, faculty inventor model. What are your thoughts on what the opportunities look like for researchers and faculty to partner, say, with startups that did not originate within the university? What does that look like? Or have you seen that unfolding here or otherwise? Or what do you think is the opportunity there?
The opportunity I see is really in terms of essentially making those connections towards the needs, problems we're trying to solve. So we are fully open in terms of people that can bring in technologies that can accelerate our research towards translation. And so those technologies don't need to be originated here. Those databases, data sources, technology sources, algorithmic aspects, implementation solutions, accelerators don't necessarily have to come from our faculty and our scientists and our learners and our inventors, but we are fully committed to and open to partner with people that are ultimately it's about solving the problems, transforming the healthcare, education, and research. And we're willing to work with anyone who is going to join us in the journey to make that happen.
Thank you. And on that, I will plug, as part of our collaboration with UNMHSC on the Health ImpACT grant for this phase, we will be partnering to make some funding and partnership opportunities potentially for researchers and interested startup technologies. If you are on either a researcher on the call at UNM or otherwise, or you at UNM or at UNMHSC, or if you are a health technology startup or company on the call and you may be interested in meeting with some of these researchers and presenting your technology, please email me and let me know. You'll hear more about that potential teaming event and funding opportunities here in the coming, hopefully, month. My other question, Dr. Raj, is you're talking a lot about the future of workforce and AI and all of the digital twins and all that great stuff. Can you speak a little to the types of programs or training or tracks that you're thinking about or working on to develop the future kind of digital ready clinical medical workforce?
Yes, thank you. Thank you. It's an exciting opportunity. We are working on developing systematic scaffolded research tracks for medical students, as well as I mentioned the master's program that maybe Dr. Amos will provide a bit more details in the AI. We are deeply integrating the biomedical engineering graduate programs with our research programs in important ways. So ultimately, it's how do we incorporate, right, deeply the innovation and engineering and technology into medicine and into medical discovery as well as translation, both as a systematic tracks as well as building enabling data platforms and computing platforms that team science, multiple teams of interdisciplinary learners can take advantage of and work on projects and as well as pursue ideas together. So those are what we are trying to enable, and having partnerships not just with within academia, but also across industry and particularly startups that are really on the bleeding edge of this technology innovation will really help all of us.
Wonderful. Thank you, Raj. That theme of collaboration and partnership across the ecosystem, working with industry. So I expect there's going to be a lot of excitement and engagement from a lot of folks here on this call. So look forward to working with you more closely. All right. Well, next we'll hear from Dr. Christopher Amos, Head of Data Science Initiatives and Associate Director for Population and Data Science at UNM Health Sciences Center. Chris will share more about some specific use cases across innovation and data science happening at the Health Sciences Center. Chris, welcome.
Thank you. One thing I wanted to say in response to the prior question is that our environment is quite flexible about, allowing us to work with companies. So we do have the capability to work outside of our regular job. So we're quite open to that. And the other thing I learned today, which is a very cool story, is that some New Mexico UNM researchers were down in the Andes, and apparently they contracted the Andes hantavirus, and so there is a report that will come out soon about the findings that have been generated from studying that. So it's kind of a nice intersection between the rural health issues that we hear about from Raj and the great technology that we have at UNM, that we've been able to tackle some of the new knowledge associated with that. That's from the Center for Global Health we work on. But I thought I would present a few specific things that I've been working on. So if we go to the next slide. One specific example is the Cancer Research Integrative Informatics System that it has been developed. It's a project at the UNM Comprehensive Cancer Center. So if we go to the next slide, the the goal was to create a user-friendly interface to facilitate clinical and population studies. In particular, the problem that we have at the Cancer Center is that we're measured based on the ability we have to launch clinical trials for new compounds and approaches that will improve cancer survivorship. But that's actually becoming increasingly challenging because the way that you match patients to trials is complicated. So part of the goal is to improve trial matching, but also to characterize how our patients match our catchment area, and also understanding how social determinants of health in the region may influence recruitment and survivorship. So this environment has been developed. It will provide opportunities for research, including evaluation of AI tools. So if we go to the next slide, UNM has a Cerner system, so all of the medical records in that system flow into this integrated data warehouse, as well as information about the cancers that patients have developed. The information from the state tumor registry goes in so that we can validate what we're getting out of our local registry. Information about treatment flows in from Mosaic. Germline and somatic reports can flow in. They right now we're switching to a different sequencing service, Keras, so that's not in yet, but it's coming. And then information about the clinical trials and social determinants of health. So we have 1.7 million unique patients in this resource. So if you go to the next slide, that's what's available. This is kind of there's a GUI that you can use to look at information, specific information about attributes of populations of patients and where they reside and what kind of social determinants of health are relevant for them. And then there's also now a sandbox environment where analytical work can be done as well. So if we go to the next slide, that's what that is. As Raj mentioned, I'm in the process of standing up a master's degree in health informatics and artificial intelligence. It's kind of a lengthy process to set up a new master's program. I have experience of having done that previously. I worked at Dartmouth before, so I know how this works. We do have some new courses in medical informatics. There's an AI in medicine program that's offered through Project Echo, which is open to anyone who would like to enroll in it. That does not provide UNM credit, so we're working on further extending that program so that it can also provide credits, but it is open to anyone. So the next slide, I'm almost done here. I just thought I would also highlight some work that's going on in our environment. There's a tumor AI lab that's run by Avinash Sahu, and he's developed programs to take information from sequencing to use large language models to understand whether those sequence variants are relevant or they're not. And also, one new application that we're working on is trying to understand the metagenome and what that does to the proteins that are expressed in different kinds of organisms that exist in our environment and really are not known. But anyway, Avi's published several papers looking at evaluating whether a variant from human genome is relevant to disease development, and also another goal of his work is to do small drug discovery for things like ovarian cancer. So anyway, those are just some of the activities that I'm aware of here. UNM's a big place. We have lots of opportunities, and we very much look forward to collaboration with our partners in the region. Thank you.
Awesome. Thank you, Chris. Another tool that came to mind as we talk about what's available locally in our state, and Synchronous, our state's health information exchange, does have the Health Equity Mapper. And so that's a tool that includes clinical and claims data, Medicaid claims data, as well as SDOH data sources. So we've got a lot of data and tools at our disposal. I think it's a matter of knowing what's out there across the ecosystem, but even this presentation was brought new insights to light. So thank you, Chris and Stefany.
Yeah, Synchronous is really open for research. They're a great organization. So yeah, it's a great resource. So I agree with that.
Yeah, your big complex data integration system architecture map kind of reminded me about how we, need some way to centralize our data, integrate it, and then surface insights like you showed. So that triggered me as well, Ange. Thank you to think of that. Dr. Amos, I do have a question. So you mentioned the data science track, which is very exciting. Is that just broadly data science, or is it specific to health sciences, or are there certain tracks?
No, this master's will be related to health, so health informatics and data science. There is actually there are training programs on the main campus in AI. So there's an AI program in electrical and computer engineering. And then there's a new program in the math department in data science. I think that's more for undergraduates. So there are some programs. There's a Grand Challenge program on the main campus called Trustworthy AI, which is focusing a little bit more on, what makes an AI development generalizable and free of bias. So there's quite a lot going on here. But that master's would be more specific to health informatics and health related components.
Oh, that's great. I mean, obviously, it's a huge need and a huge gap in our workforce, especially outside of our metro area. So that's awesome. Yeah, I did want to say, just for folks on the call, because I know we have a lot of AI aficionados and a lot of technical folks, just kind of bringing the social science aspect to it. I think, especially at UNM Maine, we have a lot of folks looking at and thinking about what does responsible AI mean, and what does bias in AI algorithms mean, and specifically when it comes to healthcare applications or even social applications, how do we ensure that our models are trained on accurately representative data that are appropriate for our unique challenges, needs, and diverse communities, as well as there's been some chatter about bringing some community-based or participatory voices into that, to think about what does it mean to design AI systems sort of for us, by us, in the context of New Mexico and especially rural care. So just wanted to let everyone know that while we talk a lot about the data and technology, and of course everyone on this call is very excited about that, there are a lot of folks at the university who are sort of thinking about the ethical and the social impact side of things as well. Awesome, thank you. I think that's all that I have.
All right, awesome. Well, again, thank you, Chris. And to close this segment, we'll hear from Alyssa Reed, Acting Rural Health Director at the New Mexico Healthcare Authority. Alyssa will speak to rural health priorities and alignment across New Mexico. Alyssa, welcome.
Thank you so much. And thank you to you, Angelica and Stefany, for inviting me and all the friends I have over at HealthInno. So appreciate all the work that you are doing. As you said, I'm Elisa Reed. I'm the acting rural health director here. I'm overseeing the state's rural health transformation program, and I'm really excited to share about this really big, really comprehensive program that we have available, and we're just at the very beginning. So I sit in the Healthcare Authority, and our mission is to ensure New Mexicans attain their highest level of health. And we are striving to have access to affordable healthcare coverage for all New Mexicans through a coordinated and seamless healthcare system. And this work really matches well with our mission, vision, and goals here at the Healthcare Authority. Today, just a couple of things I want to talk about is giving you, that high level overview of this program. It's huge. So happy to have you all go to our website and watch. There's a 50-minute webinar we did yesterday that really dives a lot more deeply into this program. So if you want more information, I'll make sure you get that website here in a minute. I want to talk about those key priorities though today, and really focus on our areas of where we see innovation happening within this program, and how you can engage with the program, especially as we're looking for partners and we have opportunities for stakeholder engagement. Really important work. I keep saying we need all hands on deck for this.
Yeah, takes a bit of a village. I just wanted to quickly check, are you sharing slides or?
Yeah, is it not sharing? Oh goodness.
Or is it just me? It might be me. It's been a long 4 hours.
It's been a long day for me. So, I may not have shared correctly. Give me a second.
Nice.
Sometimes I click share and it disappears.
All
How's
right.
that?
It's starting.
Is that
There we
better?
go. Okay.
Oh,
Topics
good.
for
Okay.
today, yes.
Sorry, y'all. I will fully admit that I am not a tech expert. I am, and it's showing right now. I'm a program person, not a tech person. All right, great. So our New Mexico Rural Health Transformation Program is a 5-year federal program. It's run through the Centers for Medicaid and Medicare Services. And we were awarded just over $211 million for year one. And that was the 13th highest across the country. Every state did apply for this. And so we're really proud to be the 13th highest of all states in the country on our first year of award. And so again, Healthcare Authority is leading this effort, but we really need all partners to help us make true transformation happen. And we are really focused in this project on access to care, workforce, sustainability of our existing healthcare system, and data to improve health outcomes. And we're really focused on those rural, frontier, and tribal communities. All right, so just a high level. This probably looks less high level than it is, but it truly is. On our timeline here, so the application from the federal government was opened in September of 25. We worked in tandem with partners, and I want to talk a little bit here in a second about what we heard from stakeholders. We used that to really design our application, which we submitted in November. December is when CMS came back and announced that we were one of the awardees of this program. So now we're in the initiation and infrastructure phase, and we're really looking for those partners to support this work. Our first report to the federal government is due in August. So, as much as we can get done between now and August to show progress would be amazing. But we do have until September 27 to spend this first year of funding. And just so you know, this is intended to be a 5-year program. So the $211 million is for this first federal fiscal year. They're giving us extra time to spend that money, thankfully. But we anticipate getting additional monies over the next 4 additional years, totaling almost $1 $1 billion for the state of New Mexico, which is a huge deal. All right, so like I said, I wanted to tell you a little bit more about what we heard from stakeholders in the design of this program. Steffi, I think you said earlier, designed by us, for us. That's really, what we try to do here at the healthcare authorities. So we did an RFI and we had 140 responses to that. The themes that we heard is that people need more access to care. That we really need to focus on more workforce development and retention, that we need more infrastructure and more data to really inform decision-making and make our healthcare system streamlined, that we need more telehealth and digital health. So making sure that we can expand our reach, especially with specialty care and whole person care models, using technology to really be able to do holistic care for rural New Mexicans, and also having stronger behavioral health in the state. So all of that information that we gathered really informed this design. So we have 5 strategic initiatives that came out of that. Healthy Horizons, which will develop health hubs, regional health hubs across the state, really focused on expanding the specialty maternal health and other specialty care that's really to really bring those things closer to home for rural New Mexicans. Rooted in New Mexico, which will really help retain and grow our workforce pipeline, our Rural Health Innovation Fund, which we really will be seeking ideas, thoughts to provide funding for folks who have ideas on how to really innovate and update how we deliver care in New Mexico in rural communities. Bridge to Resilience, which will help provide technical assistance and really be the backbone of rural healthcare operationally. And the Rural Health Data Hub, which will really help us strengthen our analytics, transparency, and predictive planning for our rural communities. All right, so innovation. The whole program really is about transformation, and you can't have transformation without innovation. And so technology, as you saw, is a really big part of this plan, and it's very much integrated into what we think will really support transformational work across rural New Mexico. So within care delivery, we really see telehealth and remote patient monitoring as opportunities to expand and increase access to care, and provider-to-provider consultation models. Data analytics, really having a statewide rural health data hub where people can access that kind of information they need to make the decisions they need on a day-to-day basis. Provider operation tools, so improving financial performance and workforce efficiencies. We want to make sure that our providers who want to care for patients can do that care for patients, and reduce the provider burden as much as possible with tools that can help them with their business and how they operate their work. And shared services and technical assistance. So that, again, that backbone operationally, and how can we use technology to really help people manage their business, manage their revenue cycles and streams, et cetera. And community access and engagement. So we already have a closer referral service system here in New Mexico called New Mexico Connect. But really, how can we leverage that and really make sure that our rural communities can have access to and get those social services that they need, and some customer and consumer-facing tools and resource navigation. We know that it's very challenging, even in urban areas, to navigate this really complex system. So how can we use technology and tools? to do that. So I think you can see really have thought about a lot of ways that we can do innovative work. We are looking to pilot, hopefully, some solutions and scale solutions through our innovation fund that's coming. So keep an eye out for that on our website. Again, I'll share that in a moment. I also wanted to touch on our health system innovation across this program. I won't talk as detailed about this because I want to save time for some questions. But we really have thought about how can we be innovative within care models, operations for sustainability within our existing healthcare systems, workforce and capacity, and partnerships and coordination across our health system. So we really, again, there's going to be more opportunities there within the health system innovation side to pilot and scale some real world solutions for rural New Mexico, and really have those ideas align with our statewide priorities. So this is an investment. This is a $1 billion investment in rural healthcare, which is a big deal. And we're really excited to be able to do this work. All right, so here is our links, and I think here in a minute, as soon as I'm stopped sharing, I can share these in the chat as well. But if you go to just this first site, which is our Healthcare Authority site, you will also find these other links that are on this page. So don't feel like you have to write down. And I just shared these slides with Stefany, so you all will get these slides hopefully after today. All right. Any questions for me?
See, I don't see any in the chat, but I just wanted, oh wait, we do have one. Okay. Where do you see technology-enabled food as medicine fitting into the state's priorities, particularly for rural, frontier, and border communities where access, referral, delivery, and follow-up are major barriers?
That's a really good question. We know that food is an essential part of everyone's health, and we have food deserts in New Mexico. So while I don't have the answer specifically to how we might utilize that technology, I can tell you that this funding really is meant to dive more deeply into those technologies and opportunities where we could use those ideas to help support things like food as medicine or other social needs. So great idea. And we know that's a major issue. So
All right, and we've got another one from Dr. Raj. What New Mexico specific opportunities do you see that will likely not be addressed by solutions found in other states that we need to pay special attention to?
that is such a good question too. I actually don't know the answer to that. And I think that's part of the design of this program is for us to bring all the bright minds and healthcare experts around the table to answer some of those questions. So I'm definitely not the expert in rural healthcare, but my job is to bring folks like you all to the table who do this work every day, who really have a deep understanding of what other states are doing, what New Mexico needs, and how we can adapt that to do it in the New Mexico way, and really come up with a streamlined strategy that really we can implement using this funding. So I don't know the answers, but I am here to help facilitate getting those answers.
Great. And then we've got another question here from Jess. Do you see the state Medicaid agency adding, specifically the Turquoise Plan, adding language to ensure MCOs will partner with HCA and startups as part of the next application process?
Oh, Jeff, that's such a good question. Hi, Jeff's my buddy. I'm not sure. I know this funding kind of goes above and beyond, even what we're doing with our MCOs. But there may be some opportunities where we can build out some partnerships and pathways so that the feedback and things that our providers are asking for and need can be incorporated. I know that's not a definitive yes or no, but yeah.
Yes, and Stefany's comment in the chat, we have a very unique opportunity to lead the charge on developing rural solutions that are widely applicable. So wonderful. Well, thank you, Elisa. We're excited about how big of a role innovation plays into your rural health transformation.
Thank you. Appreciate you all.
All right. Good afternoon, everyone, and thank you for being part of our kickoff. I mean, throughout the day, it's been a lot of conversations. We've heard a clear theme. Healthcare organizations want practical innovation support, and startups want a clear pathway to engage with healthcare systems responsibly. So let me jump right in. I'm Joseph Sapien, Program Director for HealthInno. And let's talk about what Health ImpACT is. Health ImpACT is a statewide initiative designed to help healthcare organizations surface priority challenges while reviewing, challenges while review vetted startup companies and explore structured pilots. For healthcare organizations, this means reducing burden and finding and evaluating innovation alone. For startups, it creates a pathway to engage healthcare organizations around real-world operational and clinical priorities, not just pitch into the void. So we built a network intentionally to support both sides of the equation. For healthcare organization executives, the goal is to surface relevant solutions, reduce vetting burden, which is important, and explore pilots with support from HealthInno. For startups, the opportunity is to better understand healthcare priorities, receive feedback, which is invaluable, from decision makers, and build evidence and relationships that can support long-term growth. So what does this look like? Healthcare organizations today are navigating workforce strain, access challenges, cost pressure, increasing operational complexity. We heard that a lot today. At the same time, startups are building nimble solutions. You heard from them earlier today to solve old problems in new ways. Health ImpACT is designed to help bridge that gap, creating more structured pathways for healthcare organizations and startups to explore innovation together. So what's a pilot? A lot of people have asked what a pilot is to HealthInno. So when we say pilot, we're talking about a structured time and scope bounded deployment inside the healthcare environment. The goal is not to create innovation buzz. The goal is to test feasibility, gather real world feedback, validate value. Let me say that again, validate value and help organizations make more informed decisions before broader adoption. I think we talked about that earlier in some of the earlier panels. So what we look for in startups, we focused on companies that are mature enough to engage healthcare organization responsibly. That's important, is the maturity. That means teams with a clear healthcare use, healthcare workflow fit, the ability to show value within reasonable time frame, and genuine interest in the working in New Mexico healthcare organizations. We're especially interested in founders who understand that healthcare adoption requires partnership, implementation, readiness, and long-term trust. So these are some of our categories that the state has put out for us to focus on. These are some of the innovation areas that are actively exploring through Health ImpACT. They include operational intelligence, virtual care support, workforce enablement, data modeling, early health signal detection, next generation healthcare decision support. We have these on our website as well. So if you want to look at them more in depth, you can go to our website and find those in depth on like what they actually mean and if there's alignment into your startup innovation. So let's talk about the process. Our process starts with healthcare organizations defining and sharing their priorities, which you've noticed throughout the presentations today, the QR codes and how we're trying to collect those priorities. From there, HealthInno identifies and pre-vets startup companies based on workflow fit, maturity, and alignment with support from our advisory council. Match startups are then invited to present to participating organizations, and if there's a mutual interest, pilots can move forward with support from the HealthInno team. The value HealthInno offers is we provide technical assistance to ensure pilots advance in this journey. So this is what we anticipate in our program and how we deliver it. So let's look at the timeline of how we are deploying this program. We're already in the initial phase of priority collection from healthcare organizations and early startup matching. This is what we do on a rolling basis throughout the program. Our goal is to begin launching pilot cohorts this summer and continuing supporting organizations and startups through implementation. We're learning and evaluating throughout the year. Startups will be sure to apply for healthcare organizations, submit their priorities as soon as possible so that they're included in this upcoming cohort. We've already received about 20 startup applications that have come in, so we're excited about the innovations that are coming into our pipeline. So priorities, just to give you guys a glimpse of some of the priorities that we have collected so far over the past several months. One major theme is patient access, including scheduling friction, missed appointments, navigation, and coordination gaps. I think a lot of us can relate to that. That is kind of one of the common things that we're seeing. We're also seeing a workforce and admin burden. This is something that we're all aware of, right? And so the capacity at which the workforce is able to fulfill what is happening in the environments. We're also seeing chronic and behavioral health. Healthcare leaders are also emphasizing the importance of supporting patients between visits, especially in chronic disease management and behavioral health. All right, innovation and funding statewide ecosystem. This is really exciting stuff here. We also clearly heard innovative access is uneven across the state, which is an area where policy, sustainability, and ecosystem strengthening becomes critical. Just listening to the partners in these last sessions is critical. For instance, even when promising new care models exist, organizations continue facing challenges around reimbursement and sustainable innovation funding. Without stronger coordination and shared ecosystem infrastructure, smaller and rural organizations risk being left behind. So part of Health ImpACT's role is helping create more connected statewide innovation ecosystem. So, here we go. So our call to action is, as we close today, we want to make it easy on organizations and startups to continue engaging with the Health ImpACT. For healthcare organizations, please scan the QR code and we'll take you to a short intake form where you can share your operational priorities, innovation interests, and challenges that you're facing. Our HealthInno team will then provide a participation brief outlining how the program works and what pilot exploration looks like. This is really meaningful. For health tech startups, the application process includes a short form, pitch deck submission. So just takes about 5 to 10 minutes to fill out our form, upload your pitch deck, and our team will review and see if there's a fit for pilots within New Mexico. Qualified startups will become part of our network as well, and the matching will begin at that point. So if you're interested, please send us an email. You have multiple options by scanning the QR codes if you're a healthcare organization or startup. And we're really here to help transform New Mexico's healthcare. So I want to thank you all for your time. You have our contact information. And I'm going to pass it over to Angelica to close this out.
Awesome. Thanks, folks. Thanks for everyone who hung in. Virtual events are not easy. And we also recognize we did not give you a whole lot of breaks. So appreciate you who have been here from the start. Many of you were. It was an amazing afternoon, and I hope it's clear that this isn't just a unique moment in New Mexico. It is a signal that New Mexico is building the infrastructure to responsibly adopt, test, and scale innovative solutions in healthcare. And we want the best innovators, investors, and leaders shaping what this becomes. And then before we wrap up, we're excited to officially announce the upcoming Health AI Summit on October 8th in Albuquerque. Last year's summit convened over 200 attendees. And building on today's momentum, the summit will convene healthcare organizations, AI innovators, researchers, and national leaders for a deeper conversation around applied AI implementation, workforce readiness, and the future of healthcare innovation in New Mexico. And with that, we'll open for Q&A in the chat. What questions do you have for us?
And I'm going to just put the Health AI Summit just on the screen real quick, just in case anybody wants to scan those QR codes in.
Yes.
So really excited about this as well.